So hi guys, welcome to this particular session. Okay, am I audible and visible to you? Just give me a thumbs up. Am I audible and visible to you guys in a proper manner? Just give me a thumbs up if I am. Okay, so today what we have is we have basically a one-shot FMG session where what we are going to do, we are going to revise most of the parts of the FMG. What we are going to do is we are going to cover uh, around 80-85 most important topics for your FMG exam. So that's what you're going to do rather than covering everything bit by bit or something like that. What I've decided is that we will be kind of covering it in the form of the MCQ. So what I'll do is I'll show one MCQ on the screen, and then what you are going to do, you're going to answer it, and then I'll be discussing that particular topic in kind of good detail, and I will tell you the other questions which can be asked over it or something like that. Okay, so that's the plan for today. Okay, so yep, let's kind of start. Let's talk about the FMGE kind of a one-shot revision plan for you guys. Okay, right. So the first question which you have now, this is one of the most important topics. See, there are few of the topics which they want you to know. So when you talk about the FMG, they want you to be have a very efficient knowledge as a general practitioner. So they want you to know the very basics of the diseases. That is for sure. They definitely want you to know. For example, the topics like umbilical hernia, inguinal hernia, topics like this, all these particular topics, they keep on asking you again and again and again. Okay, so let's kind of focus on these, and yeah, let's try to discuss that in detail. Okay, so yeah, you can tell me what is the diagnosis over here. So there's a 70th kind of 3-year-old male was bedridden for 15 years. What is the grade of the bed sore which is shown in this particular image? Okay, so what is it? Yes, it is the type T. Okay, so what is this? This is basically type T. So what we'll do is we'll kind of discuss the bed sore in a bit more detail. Okay, so what is this particular bed sore? What do you understand by bed sore? Bed sore is basically a trophic ulcer. Okay, what is a bed sore? Bed sore is basically a trophic ulcer. So what happens is, let's say if at all there is a patient who is bedridden. Okay, so there's a patient who is bedridden, or let's say there's a patient who has undergone a pelvic fracture. So in other words, anything which is basically causing a chronic immobilization of any particular individual. What happens if at all the patient has become immobilized? What is going to happen? These particular individuals will not be able to move on themselves, right? And they will be at the mercy of the caregivers. And if at all there is a lack of that particular caregiving, what is going to happen? And if at all they do not move, their position is basically not changed. So because of this, what is going to happen? That there's going to be the increase in the pressure built up in the soft tissue. Okay, so in the soft tissue there is going to be a very much increase in the pressure built up. Okay, so the pressure is basically going to increase in the soft tissues. Now if at all this particular pressure, it rises beyond what you call as 30 millimeters of mercury. Okay, if at all this particular pressure rises beyond the 30 millimeters of mercury, this 30 millimeters of mercury is what? This is what is your capillary closing pressure. What is this? This is what is a capillary closing pressure. Okay, so if at all the pressure rises beyond this particular 30 millimeters of mercury, what is going to happen? The microvasculature will get affected. Microvasculature is affected, and because of this the patients land up into bed sore. Okay, so these are the important things which you need to understand over here. What is the risk factor? Bedridden patients having a pelvic fracture who are chronically immobilized, they're not able to kind of move on themselves. Okay, now this is live, Mukul, this is live, this is not the recorded one, this is the live one. Okay, right, yeah. And yeah, so what you need to understand over here, and this pressure you also have to kind of remember, more than 30 millimeters of mercury, that is what is the capillary closing pressure which you have for the patients with the bed sore. Okay, I hope you have understood, right? Okay, now when we talk about the grades, so let's talk about the site. Okay, so if I ask you what is the most common site of the bed sore, can you please help me with this? What is the most common site of these particular bed sores? What is the most common site? Okay, can you please help me? What is the most common site? Okay, so the most common wrong answer which you basically get is a sacrum. Okay, so if you are answering sacrum, this is the most common wrong answer which you are basically trying to tell. The most common site is ischium. Okay, so most common site is ischium. Okay, I made this particular sign in a different manner. So ischium is the most common site. Followed by this, there is a greater trochanter. followed by this there is a sacrum, and yeah, then there is a occiput and the other things and everything. Okay, so yeah, that's what you need to understand over here. The most common site is basically the sacrum. Okay, right? So the most common site is the sacrum. Understood? Now, two things. How long will this going to be? This is approximately going to be around 5 to 6 hours around. So around 11:30 it will kind of go on. And for the PDF, I'll share my number with you guys. You can kind of just message me and I'll share the PDF with you. That's what I can do. Okay, right? Okay. So yeah, that's what is the most common site. Now, if I ask you, the next question which they keep on asking is the grades of the bed sore. So can you please help me with the grades of the bed sore? What are the grades of the bed sore which we have? Okay, so the mistake which the students end up committing is in the grade 1 bed sore. So what is a grade 1 bed sore? What is a grade 1? In the grade 1, what happens is that in the grade 1, there is no, so there is just a non-blanchable erythema. What do we have? We have a non-blanchable erythema with no loss of epidermis. Okay, so what do we have? We have a non-blanchable erythema with no loss of epidermis. That is what you basically have. Very, very important. Okay, so please do remember what is a grade 1 bed sore? Non-blanchable erythema with the no loss of epidermis. Because if at all the question, or how the questions are asked is, they will ask you that if at all, let's say there is a patient who is having a partial thickness loss of the epidermis, what is the grade of that particular bed sore? Okay, so if at all the question says there is a partial thickness loss of epidermis. Okay, so if at all there is a partial thickness loss of epidermis, what is the grade of the bed sore? The grade of the bed sore is not 1, the grade of the bed sore is grade 2. So please try to understand this point. Then the rest of the things are important, like simple rather. So what is the grade 3? In the grade 3, what happens? There is an involvement of the epidermis plus the dermis. Okay, so here there is an involvement of epidermis plus the dermis. And what about the grade 4? What about the grade 4? In the grade 4, what do we have is that underlying subcutaneous tissue is also involved. Okay, so subcutaneous tissue is also involved. So the fats and the muscles and the bones, all those particular things are involved. That is what is a grade 4 bed sore. Okay, so what is this? That is what is a grade 4 bed sore. Okay, now what about the management? So if at all, let's say there is a patient who is having a bed sore, how are you going to manage it? So management of the patients with the bed sore is what? It is debridement. It is obviously you have to kind of perform a debridement. And once you have kind of taken out all the dead and the necrotic tissue is kind of removed. After that, what you have to do is you have to perform a vac dressing. Okay, so what you have to perform is a vac dressing. Now the question which they ask you is that how much is the pressure in this particular vac dressing? So can you please help me with this? What is the pressure which you kind of put in this particular vac dressing? This is minus 125 millimeters of mercury. Okay, minus 125 millimeters of the mercury. That is what you need to understand is the kind of a pressure which you basically have in this particular vac dressing, vacuum assisted closure. Okay, got it? Right. So is this going to help the students who are preparing for the NEET PG? Yes, it's definitely going to help. So yeah, as I told you, as I always say, that knowledge is basically the same. It is just the so basically it's definitely going to help, not an issue at all. Okay, so it is going to help the students for the NEET PG as well. Okay, right. So that's how you kind of manage the patients of what you call as a bed sore. So this is one of the very, very important topic for your FMG, for the NEET PG, whatever you want to kind of say. Yes, it's a very, very important topic. Okay, now let's talk about what you call as this particular question. Okay, so the next question which we have is this. There is a patient who presented with a pain and the swelling near the angle of the mandible. The swelling was non-tender and firm for like around 3 months. What is the diagnosis of this particular patient? So what is the diagnosis over here, guys? What is the diagnosis? So the diagnosis of this particular patient is pleomorphic adenoma. What is this? This is a pleomorphic adenoma. So please look at this. Now many students confuse it with the parotid abscess. Now if at all they wanted you to mark it as a parotid abscess, they would have given you that there is a fever. They would have given you that there is a fluctuant swelling, and they would have given you that probably there is the skin changes. So skin changes basically means that there is whatever the skin has become thin, there is a erythema, there is a redness of the skin, all those particular things they would have given you if at all they wanted you to mark it as a parotid abscess. Okay, so here the answer is pleomorphic adenoma. So let's talk a bit about the pleomorphic adenoma. What do you understand by the pleomorphic adenoma? This is the one of the most common, like this is the most common tumor of the kind of a salivary gland. So pleomorphic adenoma. What is this particular pleomorphic adenoma? What you need to understand over here, this is the most common tumor of the salivary glands. Okay, this is the most common benign tumor of the salivary gland. This is the most common tumor of the parotid. All those particular things is the pleomorphic adenoma. Now, is it the benign or malignant? So yeah, it is definitely a benign tumor. Okay, so it is basically a benign tumor. And pleomorphic, what do you understand by the pleomorphic? It basically is consisting of two kind of characteristics into it. So pleomorphic, why? Because it is basically consisting of epithelial component, epithelial, as well as the stromal component. Okay, epithelial as well as the stromal component. So that is why it is called as a pleomorphic. Now, one of the characteristic features of this pleomorphic adenoma is the presence of pseudopodia. Pseudopodia. What do you understand by this particular pseudopodia? Pseudopodias are like extensions like this, which you basically have in this particular tumor. So surrounding this, what you have some kind of a capsule which is kind of present over here. Okay, now are you understand my point? So this is what is a pseudopodia. These extensions which they basically come out from this, these are what is called as a pseudopodia. Now the thing with this particular pseudopodia is, because this particular tumor has pseudopodia, because of this, enucleation is contraindicated. So if at all somebody says that, you know what, I have a patient with a pleomorphic adenoma, should I do enucleation in them? The answer is no. You cannot do enucleation in these particular patients. That is something which is contraindicated. Okay, I hope you have understood this particular point. Now, why this is contraindicated? Okay, so why this is kind of contraindicated over here? So it is contraindicated because even if you do the enucleation, you will end up removing the central part of this particular tumor, but these focus of the pseudopodia, they will kind of still remain behind, and there will be like the multifocal recurrence. So if at all you are performing the enucleation, what is going to happen? There will be multifocal recurrence. Okay, so what is going to happen over here? There's going to be a multifocal recurrence which can happen in these particular tumors, and that is why the enucleation is absolutely contraindicated. Okay, so that's what you need to understand over here. Now, what about the management? How do you manage these particular patients? So the management is, if at all somebody asks you what is the treatment of choice for the pleomorphic adenoma, the treatment of choice for the pleomorphic adenoma is superficial parotidectomy. Okay, so that is what is the what you call as the treatment of choice for the pleomorphic adenoma. That is what is a superficial parotidectomy. Okay, now what you need to understand is that in the parotid you have a superficial lobe and the deep lobe. So if at all, if the question says, if the question mentions that there is an involvement of the deep lobe, now, this is not going to be mentioned directly. So what are the points which are going to tell you that there is an involvement of the deep lobe? If they say that the tonsils are medially deviated. So you examine the oral cavity of the patient and the tonsils are medially deviated. Are you understand my point? So if at all the question kind of mentions something like that, indirectly they are telling you that there is an involvement of the deep lobe. And if at all there is an involvement of the deep lobe, then what is going to be the treatment? The treatment over here is going to be a total parotidectomy. Okay, parotidectomy. So there what you are going to remove in the total parotidectomy, you are going to remove the superficial as well as the deep lobe. Okay, superficial as well as the deep lobe. Now the last thing which you should understand in this particular pleomorphic adenoma is, I told you that this is benign. Okay, this is benign, no doubt, but in 5% of the cases, there can be malignant transformation. Okay, so what can happen in the 5% of the patients? In the 5% of the patients, there can be a malignant transformation which can happen. Okay, now what do you understand by this particular malignant transformation? So here, if at all there is a pleomorphic adenoma which comes to you with pain, which comes to you with the facial weakness, all these particular things, if at all they basically come to you, this basically tells you that there is involvement involvement of the facial nerve. There's involvement of the facial nerve. So this, if at all there is a malignant transformation, then what you have to perform? Then the treatment is going to be your radical parotidectomy. So then you have to perform a radical parotidectomy. So in the radical parotidectomy, you have to remove the superficial lobe, the deep lobe, as well as the facial nerve. So in this total parotidectomy, it's a total conservative parotidectomy where the facial nerve is preserved. But in the radical parotidectomy, even the facial nerve is kind of removed. That is what you do in the 5% of the cases when there is a malignant transformation. Okay. So this is all you need to understand about the pleomorphic adenoma, and this is the characteristic location just below the ears, anterior, and at this particular angle of mandible. That is what you need to understand, below and anterior to this particular ear. Okay, got it? Right. Okay, now let's move on to the next question. So this is a very, very important question. So please tell me what is the answer over here. Okay, so what is this particular question? I'm asking you that there is a middle-aged female, okay, and the patient is basically having the history that there is a radiation exposure. Okay, so the patient has a history of radiation exposure with a painless slow growing. Okay, so there is a history of a radiation exposure, that is kind of important, and there is a painless slow growing midline anterior neck swelling. 6 months, after 6 months, there is a cervical lymphadenopathy developed, and the surgery was done, and the image has been of the biopsy was done, and the biopsy image has been shown to you. Which of the following is not true for these particular patients? So can you please help me? What is the diagnosis over here? Like what is the answer over here? Which of the following is not true? Okay, so yes, the answer over here is FNAC. FNAC is not diagnostic. No, that is false. Okay, so first of all, can you tell me what is the diagnosis in this particular patient? So the diagnosis in this particular patient is papillary carcinoma of thyroid. Okay, what is it? It is a papillary carcinoma of the thyroid. Okay, so this is what is a papillary carcinoma of thyroid. And yes, FNAC is non-diagnostic. No, that is false. FNAC is the investigation of choice for the papillary carcinoma of thyroid. Nuclear features are the characteristics of this particular tumor. Well, yes, spread is through the lymphatics, and it has an excellent prognosis. Yes, all these particular statements are true for the papillary carcinoma of thyroid. Okay, so let's talk about the papillary carcinoma of thyroid in a bit more detail. Okay, so let's talk about the papillary carcinoma of the thyroid. So if I ask you the important things about this papillary carcinoma of thyroid, what are you going to tell me? That you know what? That this is the most common thyroid malignancy. Well, yes, that's true. This is also the thyroid malignancy with the best prognosis. Okay, so this is the thyroid malignancy with the best prognosis. So this is the most common thyroid malignancy, and this is the malignancy with the best prognosis. So these are the two important things which you need to understand. Now, if I ask you what are the risk factors, okay, so if I ask you what are the risk factors for the development of the papillary carcinoma of thyroid, what are the risk factors? So please try to understand the risk factors for the development of the papillary carcinoma of thyroid are: first is that radiation exposure in the childhood, radiation exposure in the childhood. Now, why would a child have radiation exposure in the childhood? So, for example, let's say the patient had some kind of a head and neck malignancy or something like that, and the patient had some radiation exposure because of that, and that led to the papillary carcinoma of thyroid, or like further in the life of that particular patient. Okay, so radiation exposure in the childhood. What is the other risk factor which can develop in these particular patients? So, long-standing thyroglossal cyst. Okay, so a long-standing thyroglossal cyst. Glossal cyst. Okay, a long-standing thyroglossal cyst. All these are the important risk factors for the development of your kind of papillary carcinoma of thyroid. And yes, absolutely right. What is the genetic mutation which is associated with this? So genetic mutation which is associated with this is BRAF gene mutation. What is it? It is BRAF gene mutation. BRAF gene mutation. Okay, now so this is all about it. Now, if I ask you what is the presentation, how will the patients present to you? Okay, so can you please tell me what is the presentation of these particular patients? The presentation of these particular patients is going to be that there can be a lateral aberrant thyroid nodule which moves with deglutination. Okay, so there's a lateral aberrant thyroid nodule which is basically moving with the deglutination. That's one thing. Another important thing is that there can be an occult thyroid cancer with lymph node metastasis to the neck. Okay, so there can be an occult thyroid cancer with the lymph nodal metastasis to the neck. So why these particular things are happening? Because in these particular patients there is an early lymphatic spread. Okay, there is an early lymphatic spread. Okay, so that is why these particular patients are having these particular things. Okay, so very important, lateral aberrant thyroid nodule with a lateral aberrant thyroid nodule which basically moves with the deglutination, or occult thyroid cancer with the lymph nodal metastasis to the neck. So these are the important things which you need to understand over here. Okay, right now, long-standing Hashimoto's leads to the papillary carcinoma thyroid or the lymphoma. Okay, so a long-standing Hashimoto's thyroiditis, it is more commonly leading to a thyroid lymphoma. But yes, I understand from where your question is basically coming. In Sebastian, it has mentioned that a long-standing Hashimoto's thyroiditis is also a risk factor for the papillary carcinoma thyroid, but that is a very as a low risk factor for that. So if at all somebody asks you Hashimoto's thyroiditis is associated with what, definitely it is a thyroid lymphoma. But if they ask you, is it also associated with the papillary carcinoma thyroid? The answer is yes, it can be associated, right? I hope you got your answer. Rahana, I hope you got that. Okay, got it. Now, okay, so this is about the presentation and everything. That's all fine. What about the diagnosis? If at all you have a patient with a let's say thyroid nodule or something like that, what you're going to do? FNAC is the investigation of choice, and what you're going to find on the FNAC, you basically find samoma bodies. What else do you find? You find orphan NEI nuclei, and you also find what you call as pseudo grooving. Okay, so all these are the features which you basically get in the patients with a papillary carcinoma of thyroid. So that is what is an investigation of choice for that. Okay, I hope you got that. Okay, right. Now what about the management? How are you going to manage these particular patients? The management of these particular patients is total thyroidectomy with modified radical neck dissection, plus minus rather. Okay, so if at all the lymph nodes are enlarged, then you're going to perform a modified radical neck dissection, otherwise not. Okay, now what is this particular image? What is being shown over here? So this is what is an image of a samoma body. So these are the inclusion bodies. What are these? These are the inclusion bodies which basically kind of occur in the patients with the papillary carcinoma of thyroid. Okay, so what is this? This is what is an inclusion bodies which basically develop in the which occur in the patients with the papillary carcinoma of thyroid. Okay, I hope you are able to understand this particular point. Okay, now another important thing is that okay, so that brings us to the end of your papillary carcinoma of thyroid. Let's talk a bit about your follicular carcinoma of thyroid. Okay, follicular carcinoma of thyroid. Now in the papillary carcinoma of thyroid, what did I tell you? That the lymphatic metastasis is more common. Can you please help me with the follicular carcinoma of thyroid? What do you think? Lymphatic metastasis is more common or the hematogenous metastasis is more common? So if you're answering that hematogenous metastasis is more common, yes, you're absolutely right. So over here, what you need to understand that the metastasis is more with the hematogenous route. Hematogenous is more common as compared to that of the lymphatic. Okay, you understand my point? Hematogenous metastasis is something which is more common, and this hematogenous metastasis, they are basically going to go to the bones, and in the bones, what kind of metastasis are going to develop? Osteolytic or the osteoblastic? What kind of metastasis are going to develop in the bones? So in the bones, it basically leads to osteolytic. Okay, so osteolytic metastasis is something which is going to occur in these particular bones. Okay, so osteolytic metastasis, that is what is going to occur in these particular patients. Okay, osteolytic metastasis, understood? Hematogenous metastasis, osteolytic. Now what did I tell you? FNAC, it cannot distinguish between what you call as follicular carcinoma and follicular adenoma. So please take a note of this, that it cannot distinguish between the follicular carcinoma and the follicular adenoma. This is something which you should remember. Okay, now what are the important things about your medullary carcinoma of thyroid? From where is this particular medullary carcinoma of thyroid kind of coming? Medullary carcinoma, this arises from which part? Okay, so the medullary carcinoma of thyroid, this is basically arising from the parafollicular C cells. So what is the source, or like it arises from parafollicular C cells. Okay, so this is basically arising from the parafollicular C cells. Okay, so the medullary carcinoma of thyroid, the origin of that is parafollicular C cells. Okay, so parafollicular C cells. Okay, now what you need to understand that this medullary carcinoma of thyroid, this is associated with, so somebody has written meant to be. No, it is not just meant to be. This is associated with both meant to A and meant to B. Okay, so this can be sporadic also. This can be sporadic also. I'm not saying that it cannot be sporadic, but yes, it is associated with the MEN2A and MEN2B. The familial forms of the medullary carcinoma of thyroid are associated with the MEN2A and the MEN2B. Okay, now if I ask you, what is a tumor marker? What is a tumor marker for the medullary carcinoma of thyroid? What is the tumor marker for the medullary carcinoma of thyroid? The answer over here is calcitonin. Okay, so please remember that calcitonin is the tumor marker which you basically have for the medullary carcinoma of thyroid. Okay, now if I ask you, when you perform an FNAC in these particular patients, what are you going to find? Okay, so anybody, can you help me with this? What are you going to find if at all you perform an FNAC in these particular patients? So FNAC, if at all you perform in these particular patients, you're going to find what you call as a myeloid stroma. A myeloid stroma. So these are the important one-liners. If they ask you that there was a patient who had a thyroid nodule and you performed an FNAC which showed an amyloid stroma, what is the diagnosis of that particular patient? The diagnosis of that particular patient is medullary carcinoma of thyroid. Okay, what is the diagnosis? It is a medullary carcinoma of thyroid. Okay, I hope you are able to understand this particular point. Okay, myeloid stroma, medullary carcinoma of thyroid. Then what about the metastasis? What metastasis can happen in the medullary carcinoma of thyroid? So in the medullary carcinoma of thyroid, what you need to understand, there can be a like metastasis via the hematogenous route, or there can be a metastasis via the lymphatic route. Okay, so both are basically common over here, but hematogenesis again kind of which can happen. The hematogenous metastasis can go to the bones, and in the bone what it leads to? It leads to osteoblastic metastasis. What it leads to is a osteoblastic metastasis. Doesn't lead to an osteolytic, it basically leads to an osteoblastic metastasis. So that is what you need to understand over here. Okay, osteoblastic metastasis. Now the visceral metastasis, it can basically go to the liver. Okay, so the most common visceral organ which is involved in these particular things is the liver. I hope you are able to appreciate this. Okay, so liver metastasis is basically the visceral metastasis which can happen in these particular patients. Okay, understood? I hope you have got this particular thing right. Okay, now what about the management? What is the difference, like in the medullary carcinoma of thyroid, what is so special about the management? So please understand, the management of the patients with the medullary carcinoma of thyroid is that you have to perform a total thyroidectomy, with central node dissection. Okay, so what you have to perform is a total thyroidectomy with the central node dissection. The central node has to be kind of removed in every individuals, and if at all this particular central node is kind of positive, then you basically go ahead and perform a modified radical neck dissection. Okay, so the central node is basically the sentinel node. Okay, so this is a sentinel node of your kind of thyroid. Okay, so what is the name of this particular central node? Can you please help me? What is the name of this particular central node? This is also called as a Delphian group of lymph nodes. Okay, so this is what is called as a Delphian lymph node. So this is what is a sentinel node of the thyroid, and if at all that is positive, then you proceed and then you perform a modified radical neck dissection. I hope you are able to appreciate these particular things in a better manner. Okay, got it? Right. Now lastly, we talked about the Hashimoto's thyroiditis. If at all they give you that there is a patient who is having a long standing Hashimoto's thyroiditis. This is a risk factor for what? So long-standing Hashimoto's thyroiditis, this is a risk factor for the development of your thyroid lymphoma. if at all they give you that there is a patient who is having a long standing, what you call as colloid goiter. Colloid goiter. So there's a patient who is having a long-standing colloid goiter. This is a risk factor for what? So long-standing colloid goiter, this is a risk factor for your follicular carcinoma. Okay, follicular carcinoma of the thyroid. Long-standing colloid goiter is a risk factor for your what you call as a follicular carcinoma of thyroid. Okay, so the thyroid malignancies is again a very, very important topic for you guys. I hope you have understood this point. Now let's move on to the next question. So the next question which you have is that there's a patient who presented to you after a blunt injury due to the road traffic accident and the flank bruise and injuries in the left hypochondrium. Patient is unstable. What is the next step in the management of this particular patient? Okay, so what is the next step in the management of this particular patient? Okay, so what is the next step in the management of this patient? Blunt trauma, road traffic accident, flank bruise, injury to the left hypochondrium. Patient is unstable. So the next step in the management of this particular patient is E-fast. Okay, what is it? It is E-fast. Okay, so okay, let's kind of cover a few important points regarding this. Okay, so if I ask you what is FAST stands for, okay, so sometimes the students tend to answer it. It is a focused abdominal sonography for trauma, but no, what is this? This is focused assessment sonography for trauma. Okay, what is it? This is a focused assessment sonography for trauma. It is not an abdominal sonography for trauma. Okay, now what is this? This is essentially an ultrasound which you're basically going to perform in an emergency room. So this is an ultrasound which you're basically performing in the emergency room. That's it. Okay, now if I ask you how much fluid can be detected, okay, so what is the aim of this? Okay, so whenever you kind of do anything in your life, it should have some aim. So what is the aim of performing a fast? So the aim of performing the fast is that you want to see whether there is any intraperitoneal fluid present or not. Intraperitoneal fluid present or not. For example, like you and I at this point of time, we do not have a large amount of the intraperitoneal fluid, because if at all, let's say after the trauma, if at all there is some person who is having a more amount of an intraperitoneal fluid, it is an indirect indicator that the patient is basically having some significant intra-abdominal injury. Okay, so if at all we do a fast and then we say that, you know what, that the patient is having an increased amount of intraperitoneal fluid, that is an indirect indicator that the patient is having some significant injury and now you have to take the patients for the surgery. I hope I'm making some sense to you over here. Okay, so what is the aim? Aim is basically to find out whether there is any intraperitoneal fluid accumulated in these particular patients, yes or no. Okay, now what you need to understand about this is, okay, so that is what is the aim. I hope you have understood. Now, how much amount of the fluid can be detected? How much fluid? How much fluid can be detected over here? So the fast has a capacity to detect 100 to 150 ml of the fluid. Okay, so at least 100 to 150 ml should be there for it to be kind of detected over here. Okay, understood? Got it? Now okay, so somebody is asking, sir, okay, Mukul is asking, sir, isn't E-fast the better answer for both the stable and the unstable? We'll talk about it. Okay, we'll talk about it. And Rana, it is not the 50 cc, at least 100 to 150 cc should be there. Lavanbili mentions 100, but at the other places it is given 150. So please try to understand 100 to 150 cc of the fluid has to be there for it to be detected by the fast. Okay, and yeah, we'll talk about that because we're going to cover the management protocol of your blunt abdominal trauma. Okay, so I hope you have understood the base. Okay, and how do you perform this particular fast? So what you need to understand is that we basically keep our probe at 4 locations. Okay, so we keep our probe at 4 locations. So what are the locations where we keep it? We keep it in this epigastric region. So when we keep the probe in the epigastric region, you are basically trying to look for cardiac tamponade. Cardiac tamponade. You are trying to look for cardiac tamponade. When you keep the probe at this right hypochondriac, okay, so the right hypochondriac region, you're basically trying to look for the fluid around the kind of a liver. When you're trying keeping the probe in the left hypochondriac region, you're basically trying to look for the fluid around the spleen. You're trying to look for the fluid around the liver. And when you keep the probe in this particular pelvic region, in the pelvic, you are basically trying to look for the fluid in the pelvic cavity. Okay, so you're trying to look for the fluid in the pelvic cavity. You understand my point? So these are the 4 places where you keep your probe in the fast. In the E-fast, what happens? In the E fast, that is what is called as an extended fast. In the E fast, you keep the probe at more two locations. So you basically keep it in the right and the left thorax. Okay, so when you keep it in the right and the left thorax, now you are also able to find about the pneumothorax and the hemothorax and everything. Okay, so that is what you understand by the E fast. Okay, E fast. Okay, right now let's talk about the management protocol, because many students are having the doubts in that. So let's kind of discuss the management protocol of a blunt abdominal trauma in detail. Please try to understand, whenever there is a patient who is coming to with a blunt abdominal trauma. So whenever the patient is coming to you with a blunt abdominal trauma, what is the first thing which you have to take? So you have to, first thing is that you have to rule out features of peritonitis. What do you understand by the features of peritonitis? Can you please help me with this? What do you understand by the features of the peritonitis? The features of the peritonitis basically means that whether the patient is having rigidity and guarding. Okay, so these are the features of your peritonitis. If I ask you tenderness, is tenderness a feature of your peritonitis? The answer is no. Tenderness can be present in any particular individual. So tenderness is not the feature of your kind of peritonitis. The patients have to have a rigidity or the guarding, and that basically determines whether the patients are having the features of peritonitis or not. Okay, are you understand my point? That is the first thing. So if at all the peritonitis is present, okay, if at all the peritonitis is present, no other investigation is needed. You straight away take the patients for an exploratory laparotomy. Okay, you straight away take the patients for an exploratory laparotomy. But if at all these particular features of the peritonitis are absent, okay, if at all the features of peritonitis are absent, then what you have to do, then we will see what you have to do. Okay, so that is the first thing which you have to do. You understand my point? So please understand this. Why I am kind of stressing on this so much, because many times they might give you that there is a patient with a blunt abdominal trauma, blah blah blah. They'll give you that patient is hemodynamically stable. They give you all the parameters together and everything, and very subtly they will say that on abdominal palpation there is a rigidity and the guarding. So what is the next step? So if at all the features of the peritonitis is present, you know that what is you have to do is an exploratory laparotomy. Understood? Now, if at all, let's say you have ruled out peritonitis, if at all the peritonitis has already been ruled out, okay, so if at all you have ruled out peritonitis, then what you have to do? Okay, so let's say there is a patient with a blunt abdominal trauma, and you have ruled out peritonitis. Okay, peritonitis has already been ruled out. Now what you have to do? You have to basically see whether the patients are hemodynamically stable or not. So you have to look for hemodynamic stability of the patients. Okay, so you have to look for hemodynamic stability, whether the patient is hemodynamically stable or not. Okay, if at all the hemodynamic stability is absent, okay, if at all the hemodynamic stability is not present. So first of all, what do I mean by this? Okay, what do I mean by that the hemodynamic stability is not present? What do I mean by that? I mean that the systolic blood pressure of the patient is less than 90 millimeters of mercury. Okay, so hemodynamic stability is absent basically means that the systolic blood pressure of the patient is less than 90 millimeters of mercury. In this particular scenario, what you have to do is you have to perform a fast. Okay, you have to perform a fast, and if at all the fast comes out to be positive, then what you have to do? You have to take the patients for an exploratory laparotomy. Okay, so you have to take the patients for an exploratory laparotomy. You understand my point? So you have to take the patients for an exploratory laparotomy. But if at all, let's say the fast is equivocal. What do you understand by the equivocal? Let's say the patient is very obese, and even with the help of an ultrasound you are not able to tell with surety that intrapetal fluid is present or not. That is what you mean by equivocal. So if at all the fast is equivocal, then you have to perform a diagnostic peritoneal lavage, and if at all this particular diagnostic peritoneal lavage is positive, then you take the patients for an exploratory laparotomy. You understand my point? So I hope you have got your questions answered. So whoever was asking me that, you know what, when do you perform laparotomy and all those particular stuff. So if at all the hemodynamic stability is not present and the fast is positive, then you have to perform an exploratory laparotomy. Understood? Right? Now, what about the hemodynamically stable person? So if at all the patient's hemodynamic stability is present, okay, if at all the hemodynamic stability is present, then what you have to do is, then you have to see whether the then what you have to do, you have to perform fast and you have to perform a CECT. Okay, so you have to perform a CECT abdomen as well. Okay, so you have to perform a fast, you have to perform a CECT abdomen, and based on the results of this, okay, so based on the results of this, you decide whether you have to take the patients for an exploratory laparotomy or conservative. You understand my point? So based on the results of the FAST and the CCT abdomen and the clinical kind of judgment of the patients, based on all these things together, you decide whether the patients are a candidate for your exploratory laparotomy or for the conservative management. So this is what is the management protocol of your blunt abdominal trauma. I hope you have understood this particular point. Okay, so this is what is the management protocol of your blunt abdominal trauma. I hope you have understood, right? Got it? Now let's move on to this particular question. So there's a patient who came to the emergency. Okay, so the patient was brought to the emergency after the stab injury to the abdomen. The vitals are stable. The image is kind of shown below. What is the next step of the management of this particular patient? So I'll just zoom into the image. What are you basically seeing on the image is that there is a patient who is having a stab injury to the anterior abdomen. Okay, and what is the next step? I'm asking you. So what is the next step in the management of this particular patient? Okay, so is it like the local wound exploration, IV fluids, wait and watch after dressing, and exploratory laparotomy? What do you think? What do you have to do? Okay, so here what you have to do is you have to basically perform a local wound exploration. Yes, the answer over here is a local wound exploration. It is not an exploratory laparotomy. The answer over here is a local wound exploration. Okay, so now again we are going to talk about the management protocol of a penetrating abdominal trauma. The answer is not D, guys. Okay, the answer over here is a local wound exploration. Okay, so let's try to talk about the management protocol for penetrating abdominal trauma. Penetrating abdominal trauma. Okay, so let's try to talk about the management protocol of the penetrating abdominal trauma. Okay, now just for the want of the space, I'll kind of talk about these things in the next slide. Okay, so whenever you have a patient with the penetrating trauma, what is the first thing you have to look for? The first thing which you have to look for is whether the patient is hemodynamically stable or not. Okay, so you have to look for whether the patient is hemodynamically not stable. Hemodynamically unstable. And what was the definition of hemodynamically unstable? The definition was that the systolic blood pressure is less than 90 millimeters of mercury. Okay, so what was the definition of this? That is the systolic blood pressure is less than 90 millimeters of mercury. That is what was there. Now, if at all this is the scenario, guys, okay, if at all the patient is hemodynamically unstable, do you need any other investigation? No, you do not need any other investigation. Straight away you have to kind of perform an exploratory laparotomy. Okay, straight away you have to perform an exploratory laparotomy. You need no other investigation, and straight away you have to perform an exploratory laparotomy. No other investigation is needed. Okay, I hope you are able to understand this. Okay, right? Okay, so yeah, that's what you need to understand. Hemodynamically unstable person. Now, if at all, let's say the patient is hemodynamically stable. Okay, so if at all, let's say the patient is hemodynamically stable. Okay, so if at all there is a patient who is hemodynamically stable, that means that is the systolic blood pressure of the patient is more than 90 millimeters of mercury. There can be two scenarios. What are the two scenarios which are possible? That the patient is basically having the gunshot wound, or the patient is basically having the stab wound. Okay, so let's say if at all there is a patient who is having a gunshot wound. This particular gunshot wound can happen again at the anterior abdomen, or it can basically happen in the back or the flanks. You understand my point? So you can have a what you call as a this particular stuff into the anterior abdomen or in the back or the flanks. So if at all there is a patient who is having a gunshot wound into the anterior abdomen, what you need to understand is you need no other investigation. And straight away you take the patients for an exploratory laparotomy. So here what you need to understand is here there is an exploratory laparotomy. Okay, but if at all there is a patient who is having a gunshot wound in the back or the flanks, what you perform is you perform a CT scan, and if at all the CT scan shows some positive signs and the features and everything, then you have to kind of perform an exploratory laparotomy. So please try to understand, not all the gunshot wound to the anterior abdomen, they are basically taken directly to the exploratory laparotomy, but the gunshot wound to the back and the flanks, you have to first perform a CCT, and if at all that the CT scan is kind of positive, then you go ahead with an exploratory laparotomy. I hope you're able to understand this point. Okay, now what else? So let's talk about the stab wounds. Now the stab wounds can again happen to these particular places, right? So the stab wound can happen, what is basically, it can happen to what you call as your back or the flank. Okay, so if at all there is a stab wound which is basically happening to the back or the flank, again the same thing has to be done. You have to kind of perform a CT scan, and if at all that particular CT scan is positive, then you take the patients for an exploratory laparotomy. Okay, you have to perform a stab wound, and then you have to kind of go ahead and do an exploratory laparotomy. Okay, now what about the stab wound? Now if at all, let's say the stab wound is associated, I'll just get out of the view so that you will be able to appreciate the table in a better manner. So if at all, let's say there is a stab wound which is basically happening, what you call as which is associated with evisceration or the bile staining of the clots. Okay, so what do you understand with an evisceration or the bile staining of the clots? Evisceration basically means, let's say the intestine is basically coming out of the abdomen, okay, or let's say some part of the intestine or the liver or something is basically coming out of the abdomen. Now you understand my point. So this is what is called as an evisceration or bile staining of the clots. And if at all there is a evisceration or the bile staining of the clot, then again no other investigation is needed, but you have to directly take the patients for an exploratory laparotomy. No other investigation is needed. Straight away you go ahead with the exploratory laparotomy. I hope you are able to understand this particular point, guys. Okay, evisceration or the bile staining. What do you understand by bile staining? So when will the bile staining happen? If at all there is an injury to the gallbladder or the bile duct or something like that. I understand my point. So yeah, that is what you need to understand. Now lastly, if at all, let's say there is an stab injury to the anterior abdomen. Okay, so now what you need to understand is that this is a scenario which has been shown to you in this particular image, right? So in the image, what you have this particular stab injury. What is this? This is what is a stab injury which has happened to the anterior abdomen. Okay, so this is a stab injury which has happened to the anterior abdomen, and they are asking you like what you have to do with this particular stuff. Okay, so the answer, as I told you, is a local wound exploration. Okay, so local wound explorations. So whenever you have this particular stab injury to the anterior abdomen, what you have to perform is a local wound exploration, LWE. LWE basically stands for your local wound exploration. Now please pay attention. Why do you have to perform this local wound exploration? So you have to perform a local wound exploration because you want to know whether the peritoneum has been breached or not. Okay, you understand my point? So for example, let's say there is an individual. Okay, let's say there is an individual. Okay, and let's say this is the peritoneum of the patient. Let's say this is the skin of the patient. Okay, now what is basically present over here? There's a subcutaneous tissue, fat, and all those particular stuff. Okay, now let's assume that there is a stab injury to this particular patient. Okay, so this is the stab injury 1A and this is the stab injury B. Okay, now what you need to understand is what are we concerned about? We are concerned whether the tip of that particular knife or a sword or whatever, did it cross this particular peritoneum or not? Because only when it is going to cross this particular peritoneum, only then it has a chance of injuring some intra-abdominal organ. Are you understanding my point? If at all it is just over here, you are sure that no major significant intra-abdominal injury has happened in this particular patient, right? And that is the reason why you have to perform a local wound exploration. So local wound exploration, what is the aim of performing a local wound exploration? To see whether the peritoneum has been breached or not. So if at all the local wound exploration is positive, then what you're going to do? You're going to admit the patients. You are going to monitor the patients, and if at all the patient deteriorates, then you basically have to perform this exploratory laparotomy. If at all the patient deteriorates, now you perform this exploratory laparotomy. I hope you are able to understand this particular point. These are very, very important topics. So in the trauma, the two of the most important things which you should remember is management protocol of your blunt abdominal trauma and the management protocol of your penetrating abdominal trauma. I hope you are able to understand these particular things, guys. Okay. Now, Mukul is asking about zone 2. So please try to understand that zone 1, zone 2, zone 3, that is for the retroperitoneum. That is not for this abdominal injuries and all. Okay, Mukul. So that is the zone 2, zone 1, zone 2, zone 3. These are the injuries of the retroperitoneum. So if at all there is a zone 2 injury, if at all there is a penetrating injury, then you explore. But if at all there is a blunt trauma and the patient is stable, then you do not explore. In the zone 1, all the injuries you have to explore, and in the zone 3, you try your level best not to explore, because in the zone 3, which is basically occurring in the pelvis, the space to operate is very, very less. And if at all the space to operate is very, very less, even if you try to kind of do good for the patients, you might not be able to save that particular patient. So you try your level best to kind of manage the patients conservatively. So just revising, in the retroperitoneum, there is a zone 1, zone 2, zone 3. In the zone 1, any injury, blunt or penetrating, you have to kind of go ahead with an exploratory laparotomy. In the zone 2, what you need to understand is, if at all there is a penetrating injury, you have to kind of explore. But if at all, let's say there is a blunt trauma and the patient is stable, then conservative management. And in the zone 3, you try your level best for the conservative management. It's not like that you cannot explore. You can explore as a desperate measure, but even when you explore, the mortality is very, very high. 50-60% is the mortality even after you explore these particular patients. Okay, so that's all you need to understand over here. Okay, now let's move on to the next question. The next question which we have, guys, that there is a 35-year-old kind of patient presented with the severe abdominal pain and the vomiting. So what you have over here, that there is a patient who presented with the severe abdominal pain and the vomiting. His vitals are kind of stable. The radiograph is kind of given below. What is the most effective way to treat this particular patient? So what are you basically finding in this particular patient is that a very, very important X-ray. So can you please tell me what are you finding in this particular X-ray? So what you're basically finding is a gas under diaphragm. Okay, you're finding a gas under diaphragm. So if at all you have a gas under diaphragm, what you need to understand is that this basically tells you that there is a visceral perforation. And if at all there is a visceral perforation, what you have to perform over here, you have to perform what you call as a resuscitation with an exploratory laparotomy. So whenever you have this particular what you call as this gas under diaphragm, then you have to perform a resuscitation with an exploratory laparotomy. So it is not a cupola sign. Cupola sign is basically when you have the gas under diaphragm, like on the both the domes. Under both the domes of the diaphragm, at all you have a gas, that is what is called as cupola sign. Okay, so that's a different story. This is simple gas under diaphragm, which is denoting your visceral perforation. Okay, now this is an important clinical scenario. There is a 30-year-old male patient presented with a recurrent painful perianal nodule on the buttocks with a serous discharge. So what is coming out? So there's a nodule over here. Okay, so what do you have? You have a nodule over here, and from here what is basically coming out is a serous discharge is basically coming out from this particular nodule. Okay, now what is the most probable diagnosis of this particular patient? What is the most probable diagnosis? Is it like the perianal boil, carbuncle, fistula in ano, or the pilonidal sinus? What is the diagnosis of this particular patient? It is not the pilonidal sinus, guys. Okay, it is not the pilonidal sinus. Pilonidal sinus, the history is going to be that there is a truck driver who is basically having a kind of a sinus in the midline, in the sacrum region. Okay, and that is what is the characteristic thing of a pilonidal sinus. Over here, yes, the answer is fistula. So this is what is a fistula in ano, guys. Okay, so please remember what is this? This is what is a fistula in ano. What is the answer over here? It is a fistula in ano. Okay, so what do you understand by a fistula? Fistula basically means that there is what you call as the two openings. Okay, fistula basically means that there are two openings. So fistula basically means that there are two openings. Two openings. One is basically in the rectum or anal canal. Okay, so one opening in the anal canal and the another opening is basically in the skin. Okay, so there's one opening in the anal canal, another opening is in the skin. So the fistula has basically two openings, one in the anal canal, one on the skin. Are you understanding? And from this particular fistula, what is basically coming out is a serous discharge, serous or a purulent discharge, purulent discharge. Okay, serous or a purulent discharge is basically coming out from this particular stuff, and that is what you need to understand over here. Okay, understood? Now, why this happens? So there is a perianal abscess, and this perianal abscess, when it basically bursts, like it can burst internally, it can burst externally, or you can kind of do an IND or something like that. And in this particular manner, what you have is you basically have this fistula formation. Okay, so now let's talk about a couple of important points about this perianal fistula. We have already talked about the clinical presentation. What is going to be the clinical presentation? That there's going to be a serous or a seropurulent discharge, which is coming from this particular kind of a point. Okay, what this particular fistula is tracked, what comes out is a serous or a purulent discharge, purulent discharge. Okay, so this is what is basically coming out. Now, if I ask you about the diagnosis, how are you going to do a diagnosis of this particular patient? Can you please help me with this? How are you going to diagnose these particular patients? So the diagnosis of these particular patients is basically done. It can be clinical diagnosis can help. That's one thing. Another important thing is if I ask you what is an investigation of choice to diagnose these particular patients, the answer is MR fistulography. Fistulography. So what are the things which you're going to get to know with this MR fistulography? So please understand MRI. MRI is the investigation of choice to diagnose the perianal fistulas. What are you going to get in these particular MR fistulography? You're basically going to get whether it is a simple fistula or the complex fistula, what is the where is the internal opening present, whether it has a multiple cross communications or not, and yeah, like whether it is a high lying fistula, low lying fistula. All these particular informations you're going to get with the what you call as an MR fistulography. So please try to understand this point. This is what you're going to get on the MR fistulography. Now that's what you need to understand. Okay, and what else? Okay, let's talk about the management. Okay, so how are you going to manage the patients of this particular perianal fistula? How are you going to do that? So the management of the patients of this particular perianal fistula is that what is the treatment of choice? The treatment of choice over here is not the fistulectomy. So please never mark it as a fistulectomy. What is the treatment of choice? The treatment of choice over here is a fistulotomy. Okay, so fistulotomy. What do you understand by the fistulotomy? It means that laying open of the fistulous tract. Okay, so what you do is you lay open this fistulous tract. That is what is called as a fistulotomy. Okay, are you understanding my point? So you lay open the fistulous tract. That is what is called as a fistulotomy. Okay, right. Now, what is this? What are you basically seeing in this particular image? So you're basically seeing seton. What is the seton? So seton is basically a thread which you basically pass from the internal opening and the external opening, and then you tie it over here. And this particular thread is basically made up of a non-inert material. So this is a non-reactive material. Okay, so what is this? This is what is a non-reactive material. So rather it is an inert. Okay, this is made up of an inert material. This particular thread is made up of an inert material. Are you understanding my point? So what is the seton? Seton is basically a thread which is made up of an inert or a non-reactive material, and that particular thread basically goes through the internal opening, comes out to the external opening, and then you basically tie a knot and all those particular things. This is what is referred to as a seton. Now the seton can be of two types. Okay, so please try to understand. This seton can be of two types. There can be a draining seton. Okay, so there can be a draining seton or there can be a cutting seton. What do you understand by a draining and what do you understand by a cutting seton? Draining seton is basically used when you basically have a kind of a purulent discharge. Purulent discharge. Okay, so when you have a purulent discharge and when you have to kind of drain this particular abscess, then what you have is a that is what you basically have is a draining seton. Draining seton is basically for the pus or the purulent discharge. That's what you need to understand over here. Okay, and what about the cutting seton? So cutting seton is basically okay, so what about the cutting seton? Cutting seton is basically what you need to do is the cutting seton is basically used for the treatment. So this is basically used for the treatment if at all you are dealing with an immunocompromised patients, or let's say you are dealing with what you call as high lying fistulas. Okay, if at all there is a high lying fistula. So if at all they kind of mention that there is a high lying fistula or there is a immunocompromised patients, in that what is the treatment? For example, if they give you that there is a patient with an AIDS and the patient is having a fistula in ano, what is the treatment of choice for that particular patient? It is what is a cutting seton. Okay, I hope you are able to understand this particular point. Okay, so mid school mnemonics. Converting a high-lying fistula into the low-lying, no, you cannot do that. Okay, so in the cutting seton, what you do is you basically cut that entire tract and ultimately you kind of bring that particular cutting thread kind of outside. Are you understanding my point? So what happens is that it gives time for the muscle to heal also simultaneously, and that is how the complete incontinence may not happen. The strength of the muscle basically comes down, but the complete incontinence may not happen. Okay, so that is what you need to understand. Okay, right, yes. So Yeah, Nabi. So yeah, I hope you have understood. Yes, I did mention it. So this is important for, let's say, if at all there's a patient who is having AIDS or an HIV, and then they ask you that the patient is having a fistula in ano, and how are you going to manage these particular patients? You're going to manage these particular patients with the help of a cutting seton. Okay, so how you're going to manage these particular patients? You're going to manage these patients with the help of a cutting seton. Okay, understood? Now let's move to the next question. So there's a 30-year-old patient presenting with the casualty. Okay, so there's a patient who's coming to the emergency after the motor vehicle accident. He has the bruise over his chest. His pulse rate is 120 per minute. The blood pressure is 90 by 60 millimeters of mercury. The respiratory rate is 40 per minute. The chest x-ray was performed and it has been shown below. What is the next most appropriate step in the management of this particular patient? So this is what is the chest x-ray which you're basically seeing. You understand my point? So what is the diagnosis over here? Please help me. What is the diagnosis? The diagnosis over here, this is one of the very important x-rays for you, at least for the FMGE exam. This is a very important x-ray, and if you commit a mistake with this, that is not acceptable. Okay, so the diagnosis over here is the pneumothorax. What you're basically having over here is a pneumothorax, and over here, yeah, the answer over here is the chest tube drainage insertion, and yeah, that's what you need to understand. It's not the emergency thoracotomy. Obviously, you do not do that. The diagnosis over here is a pneumothorax. Now, why do I say that the diagnosis over here is a pneumothorax? Because I hope you're able to appreciate that this is a part of the lung where this is more black as compared to the other side. Okay, what has happened over here? That is the lung has basically collapsed. The lung has collapsed, and this particular part of the lung is more black as compared to the opposite side. So this is what is a pneumothorax. Okay, what is this? This is what is a pneumothorax. Okay, now let's talk about the tension pneumothorax. What do you understand by the tension pneumothorax? In the tension pneumothorax, what you need to understand, there is a formation of a flap valve. So rather, there is a formation of a valve. Valve is kind of present in these particular patients. And what does this particular valve do? The valve allows the flow of the air only in one direction. So what is this valve going to do? This is going to allow air to enter the thorax, but will not allow it to leave the thoracic cavity. Are you understand my point? So this is going to allow the air to enter into the thoracic cavity, but it will not allow the air to leave the thoracic cavity. That is what you need to understand about the valve. Okay, so this is what you understand by the valve. Now, because of this, what is going to happen? Because of this, the patients are going to have what you call as respiratory distress. Along with this, what is going to happen? The patients are going to have tracheal deviation to the opposite side. So for example, there is a pneumothorax of the right side, the trachea will be deviated towards the left. Then what else? The patients are going to have absence of the breath sounds. There's going to be a resonant note, hyperresonant note on percussion. And along with these, if at all, they also mention that there is a raised JVP. Jugular venous pressure is basically raised, and the patient is hemodynamically unstable. Okay, so if at all they mention these particular things, that the JVP is raised and the patient is hemodynamically unstable, then we say that, you know what, the patient is basically having tension pneumothorax. Then we say that the patient is having a tension pneumothorax. Are you understand my point? So then we say that the patient is basically having a tension pneumothorax. Are you understand my point? Now, the very important thing which you need to understand is the management. Okay, so the above four things. Okay, so these above four things, if at all the patient is having only these four things, then the patient is basically having a simple pneumothorax. Okay, and then the patient is having a simple pneumothorax. Okay, then the patient is having a simple pneumothorax. But along with that, if at all the patient is also having the raised JVP and the hemodynamic instability, then the patient is basically having a tension pneumothorax. I hope you are able to understand this point. Okay, now let's talk about the management. How do you manage the patients of a tension pneumothorax? Okay, for the tension pneumothorax, how are you going to manage the patients of attention pneumothorax. So there is something which is called as an emergency management, and there is something which is called as a definitive management. What about an emergency management? Emergency management is basically by putting a wide bore needle. Okay, in the emergency management, what you do is you put a wide bore needle in cases of an adults and in cases of children. Okay, so in case of children, this particular wide bore needle is basically put in the second intercostal space in the mid clavicular line. Okay, so in the mid clavicular line in the second intercostal space, you basically put a wide bore needle. Okay, second intercostal space. What about in the adults? In the adults, you basically put it in the fifth intercostal space in the mid axillary line. Okay, in the mid axillary line in the fifth intercostal space, you put a wide bore needle in the adults. Are you understand my point? This is what is an emergency management. What about a definitive management? So definitive management is basically putting a intercostal drain in the fifth intercostal space in the mid axillary line. Okay, so this is putting an ICD in the fifth intercostal space in the mid axillary line. Please understand this. This is very important. Okay, understood? Right. So this is about the pneumothorax. Now again, the pneumothorax is one of the very important topics for your FMG. So please understand that. Okay. Now let's talk about this. So there's a 45-year-old patient complaining of a recurrent swelling in the one side of the neck. She's afraid of eating food as it worsens the swelling. Imaging was performed, which has shown below. What is the most likely diagnosis of this particular patient? Okay, so imaging has been performed, which has been shown below. What is the most likely diagnosis? Okay, yes, the answer over here is a sialolithiasis. So what is this? This is what is a salivary gland stones. Okay, so what is this? This is what is a salivary gland stones which you're basically having over here. Okay, so now let's talk about the couple of important points about this particular salivary gland stone. So if I ask you, which is the most common salivary gland where we have the salivary gland stones, where we have the salivary gland stones, okay, which is the most common salivary gland where the salivary gland stones occur? It is the submandibular. Okay, submandibular salivary gland is the most common salivary gland where the salivary gland stones occur. Are you understand my point? This is the most common salivary gland where the salivary gland stones occur. Now why this is so? Can anybody tell me the reason why this is so? So please try to understand. Assume that this is a submandibular salivary gland and this is the duct of the submandibular salivary gland. This duct of the submandibular salivary gland is hooked by a nerve. So which nerve is basically hooking this particular kind of duct? So please try to understand. It is hooked by lingual nerve. Okay, so it is hooked by the lingual nerve. Okay, it is hooked by the lingual nerve, and because it is hooked by the lingual nerve, what is going to happen? That there is going to be an anti-gravity drainage. Okay, there is going to be an anti-gravity drainage, and because of this, what happens? There are the salivary gland stones which basically develop in this submandibular salivary glands. Okay, so salivary gland stones, they basically develop in this submandibular duct and the submandibular salivary gland. Are you understanding my point? So yeah, that is what you need to understand. Now here, the clinical features are going to be like this. Okay, so what is going to be there? So in the clinical features, the patients are going to have that there is a pain and the swelling in the submandibular salivary gland. So what is going to happen? There's going to be the pain and the swelling in the submandibular salivary gland, mandibular salivary gland, and what else? So there's going to be the pain and the swelling in the submandibular salivary gland, and what else? So there's going to be what you call as postprandial swelling. Okay, so there's going to be the postprandial swelling. What do you understand by the postprandial swelling? Postprandial swelling basically means that after you have eaten the food. Okay, so after you have eaten the food, so what happens is when we eat the food. Okay, so when we eat the food, what happens? That there is salivation. Okay, so when you eat the food, there is a salivation, and if at all the saliva is not able to come out, okay, if at all the saliva is not able to come out, it is going to get accumulated over here, and there's going to be the postprandial swelling. So after you have eaten the food, there's going to be the swelling and the pain in these particular kind of a place. Okay, so that's what you need to understand. Pain aggravated by the spicy food or by the food. That's fine. Okay, now the important thing which you need to understand over here is that the submandibular salivary gland is associated with certain nerves. So what are the nerves which are in association with the submandibular salivary gland? Mandibular salivary glands. Salivary gland. What are the nerves which are associated with this submandibular salivary gland? So we have what we call as the lingual nerve. Obviously, we have the lingual nerve. What else? We have a hypoglossal nerve, and what we have is a marginal mandibular nerve. You understand my point? So what are the nerves which are associated with the submandibular salivary gland? Lingual nerve, hypoglossal nerve, and the marginal mandibular nerve. These are the three nerves which are associated with your kind of a submandibular salivary gland. It is not the facial. Okay, yeah, so facial is not associated with this submandibular salivary glands. Please try to understand this. Marginal mandibular is the third one. Okay, right? Okay, obviously, if when you do the surgeries, what is the most common nerve which is injured? So the most common nerve which is injured is the lingual nerve. Lingual nerve is the one which is most commonly injured during the surgery of this particular thing. Okay. Okay. Yeah. Okay, that's great. So thank you so much, Shweta. Thank you so much for that. Yeah, that's fine. Now, what we'll do is, yeah, let's move to the next question. In a couple of minutes, I'll take a break or something. Okay. Now, yeah, what is the next question? So the patient presented with the emergency with the claudication of the calf muscles and the numbness of the thigh and the impotence, the bilateral resting pain. The image is showing the gangrene of the foot below. What is the artery which is involved? So whenever you get the questions like this, what you need to understand is that what are the things which are given in this particular protocol as the question. So what are the things which are given? So we have what we call as an intermittent claudication on the calf muscles. That's one thing which is given. What else is given? So we have that there is a numbness in the thigh and there is impotence. So whenever there is an impotence, why will the impotence occur? Because the blood supply to the penis is basically reduced from the internal pudendal artery. So whenever you have impotence in the patients with the peripheral vascular disease, in the peripheral vascular disease, whenever you have this particular impotence, you feel that, you know what, there is an involvement of an iliac vessel. So iliac vessels are kind of involved over here. You understand my point? So yes, that is what is an aorto-iliac bifurcation. So here what you have is that either there is a kind of a peripheral vascular disease or atherosclerosis or whatever, but here there is an involvement of an aorto-iliac bifurcation. So that is why you have this particular impotence over here. That is what is a Leriche syndrome. Okay, I hope you have understood this particular point. Okay, right. And yeah, that's what you need to understand over here. So there are other things also. We'll talk about this. There's another question on this. We'll talk about this. Okay, right. Now, there's an alcoholic. Okay, so okay, what I'll do is I'll just take a small break of around 5 minutes. We'll get back after, let's say 6:25. We'll be back again. Okay, so just take a small break. We'll meet back at 6:25. Yeah, that's what. Hello. Yeah. Hi guys. So yeah, let's start. Sorry for the bit of a delay. There was some work which I had to do. Okay. Anyway, so yeah, let's kind of continue what we were trying to talk to you about. Yeah. So what we are trying to say over here, what is the next thing which you're trying to do? That there is an alcoholic patient. Okay. So yeah, let's I hope you have joined back. There's a bit. Yeah. Am I audible and visible properly? Yeah, I hope I am. Okay. Got it. So let's start. Let's start by talking about the things further. Okay, so the next thing which we're going to cover over here is that there's a patient who is basically alcoholic, and the patient is basically coming to you with what? The patient is coming to you with the loose motions from the few days, presented with the pain in the right hypochondrium and the fever, and the ultrasound shows that there is a liver abscess of 75 cc in the volume. What is the next best step in the management of this particular patient? So here, what you need to understand is that there is a patient who is alcoholic. The patient is having loose stools, and the patient is having pain in right hypochondrium. Okay, and yeah, there is a liver abscess. Okay, so what is the first of all, let me know what is the diagnosis of this particular patient. So the answer over here, what is the diagnosis of this particular patient is, it is an amoebic liver abscess. Okay, what is it? This is an amoebic liver abscess. And if at all there is an amoebic liver abscess, what is going to be the management of the patients? The management is going to be a medical management. Okay, so what is the management going to be? It is going to be the medical management. No, it is not the aspiration and the drainage. Okay, so that's what you need to understand over here. It is not the percutaneous drainage, guys. Okay, why? Because the diagnosis over here is an amoebic liver abscess. Why it is an amoebic liver abscess? Because alcoholism and loose motion. So amoebiasis led to the loose stools, led to the liver abscess. I understand my point. They've not given you these things just for the sake of it. An alcoholic patient, why they have given you the alcoholic patient, why they have given you the loose stools? Because they want you to kind of think on the terms of an amoebic liver abscess. Am I making some sense to you guys here? So because they want you to think in the terms of the amoebic liver abscess, and the management of the amoebic liver abscess is a medical management which is metronidazole, and that is what they are trying to kind of bring into your notice. I hope you're able to understand this particular point over here. Okay, so here, what is the kind of a thing over here? Amoebic liver abscess, the diagnosis and the management of this particular patient is yes. Okay, yes. So drainage is basically for the aspiration and the drainage. Yeah, that's fine. Okay, right. Okay, so let's talk about this amoebic liver abscess and this pyogenic liver abscess and all. So what do we have? We have the two types. What we have is, we have amoebic and we have a pyogenic. Okay, so what is the most common cause of a pyogenic liver abscess? So organism which is associated with the pyogenic liver abscess is E. coli. And what happens is that, let's assume that this is the liver, and let's assume that this is the right and the left kind of hepatic duct, common hepatic duct, cystic duct, common bile duct, all those particular stuff. So let's say if at all there is some stone inside this particular common bile duct. So there is a stone in the common bile duct. So what is going to happen? The bile is going to get accumulated just proximal to that particular stone, and there can be infection, and that particular infection can basically ascend up into the liver. Okay, so that particular infection can ascend up into the liver, and it can lead to the multiple liver abscess. Okay, so this is what is the pathogenesis of a pyogenic liver abscess. So what is the most common route of spread of the liver abscess, like the pyogenic liver abscess? In the pyogenic liver abscess, what you need to understand, the most common route of the spread is the ascent of the infection. Okay, ascent of the infection from the biliary tree. That is what is the most common route of the spread in the pyogenic liver abscess. Okay, so ascent of the infection from the biliary tree, that is what is the most common route of the spread in the pyogenic liver abscess. Okay, now what about the amoebic liver abscess over here? What is the organism which is associated with the amoebic liver abscess? The organism which is associated with the amoebic liver abscess, we all know it is an entamoeba histolytica. Now the histolytica. Okay, now they keep on asking you about the infective stage. Okay, so what is the infective stage for this amoebic liver abscess? What is the infective stage? The infective stage for the amoebic liver abscess is, what is it? It is a quadrivalent quadrinucleate cyst. What is it? It is a quadrinucleate cyst. So the infective stage for the amoebic liver abscess is your quadrinucleate cyst. Quadrinucleate cyst. Yeah. In the pyogenic liver abscess, this is more associated with the jaundice. So jaundice is basically present in 25% of the patients in this, and that is why the alkaline phosphatase levels are high in the pyogenic liver abscess. ALP levels are high because the jaundice is associated with around 25% of the patients. Okay. Now let's talk about the amoebic liver abscess. What you need to understand is this quadrinucleate cyst. This quadrinucleate cyst, this basically kind of gives rise to trophozoites. And these particular trophozoites are basically released into the cecum and ascending colon, where they basically lead to a flask shaped ulcer. Okay, so here in the cecum and the ascending colon, they lead to the flask shaped ulcers, and the trophozoites are present inside this particular flask shaped ulcers. Now these particular trophozoites, they enter into the bloodstream. So they enter into the bloodstream and they reach to the liver. Okay, so they enter into the bloodstream and they reach to the liver, and in the liver they can lead to enzymatic degeneration. Okay, so they can lead to an enzymatic degeneration, and because they're leading to the enzymatic degeneration in the liver, it leads to the formation of an abscess, which is a collection of your dead hepatocytes plus RBCs. Okay, so dead hepatocytes and the RBCs, they basically get accumulated inside the liver, and that is what is called as an anchovy sauce pus. Okay, what is this referred to as? This is what is called as an, this is what is a amoebic liver abscess, which is also referred to as your anchovy sauce pus. Okay, so what is this? Anchovy sauce pus or the amoebic liver abscess. I hope you are able to understand this point. This is what is the pathogenesis of this. Okay, now lastly, if they ask you what is an investigation of choice. Okay, so investigation of choice for the pyogenic and the investigation of choice for the amoebic. Okay, so what is an investigation of choice for the pyogenic and what is an investigation of choice for the amoebic? So for the pyogenic liver abscess, the investigation of choice is aspiration and culture. What is it? It is aspiration and the culture. For the amoebic liver abscess, it is serology. Okay, to be specific, it is like ELISA or the serology. That is what is the the investigation of choice for the amoebic liver abscess. Okay, now coming to the management, how are you going to manage the patients? In the amoebic liver abscess, the mainstay of the management is medical. Medical basically means that metronidazole. You basically give 750 milligrams 3 times a day for around 10 to 14 days. Metronidazole, you basically give that. Okay, so metronidazole, you basically give 750 milligrams for around 10 to 14 days. That is what is the medical management for the amoebic liver abscess. For the pyogenic liver abscess, what is the management? For the pyogenic liver abscess, the management is drainage with pigtail. Obviously, along with that, you have to give antibiotics to the patient. Okay, so along with that, you have to give the antibiotics to these particular patients, but the management is basically what you call as drainage with the antibiotics. Okay, so just give me a minute, guys. Just give me a minute. Okay, so yeah, so that's what you need to understand, amoebic and the pyogenic liver abscess. Okay, so this is how you manage the patients of an amoebic and the pyogenic liver abscess. Okay, very, very important. All these things are important. Okay, now let's talk about this. So again, one of the very, very simple questions: a 22-year-old male patient underwent a surgery on the chest after the road traffic accident 1 year back. The image of the lesion is shown in this particular picture. What is the probable diagnosis of this particular patient? So this is what is a image which has been shown to you, and what we're trying to ask you is that what is the diagnosis of this particular patient? So yeah, what is this? So pretty simple, one of the most simplest of the questions which can be asked to you. What is this? This is what is your hypertrophic scar. Okay, so what is this? This is what is your hypertrophic scar. So now let's talk about the what you call as a derangements from the scar formation. So what we can have is a keloid, and we can have a hypertrophic scar. So what you need to understand is, first of all, what is the most common location? So the location of these particular stuff is in the sternum. Most common location is basically in the sternum. So this is basically the like once you join the two shoulders and the xiphisternum together, the area which is between this is most likely to be suffering from, or the hypertrophic scar and the keloid, they are most likely to occur in this particular area, the between the two shoulders and the xiphisternum. So this is the area where the abnormalities of the scar formation will be the maximum. Okay, now what about the keloid and the hypertrophic scar? A couple of things about the hypertrophic scar is that it tends to be better with the time. It tends to get better with time. This has no familial association. No familial association. And obviously we all know the definitions of the hypertrophic scar, right? So if at all that particular abnormality or the growth of that particular scar is well within the boundary of that particular scar, that is what is called as a hypertrophic scar. But if at all that particular abnormality, it basically goes beyond the boundary of the scar, that is what is a keloid. Okay, so what is a keloid? Keloid is when the growth or whatever the abnormality of that particular scar is beyond the boundary of the scar. Okay, so when the growth of that abnormality of the scar or whatever is beyond the boundary. Okay, it's beyond the boundary of the scar. That is what is called as a keloid. That's fine. Okay, and this has a family predisposition. It doesn't get better with time. Do not get better with time, and this has a familial association. Familial association is present in these particular patients. Okay, so that's all you need to understand. Now, what about the management? So for the management, there's not a well-defined kind of a thing, but what you need to understand is primarily what you basically try is an intralesional triamcinolone. What do you understand with this triamcinolone? Triamcinolone basically is a steroid. Okay, so this is what is a steroid. So what you do is you inject the steroid into this particular lesion. Okay, so this is what is called as an intralesional triamcinolone injection. Okay, so you inject the steroid into that particular kind of abnormality of that particular scar. Are you understand my point? So this is what is the primary treatment. If at all this particular thing fails, okay, if at all this fails, then you have to perform an excision. Okay, so then what you have to perform is an excision. Okay, so then you have to kind of perform an excision, and along with the excision you need that hydrocolloid dressing or the compression dressings and all those particular things, because you want to prevent the recurrence. Okay, excision along with the suturing, along with that hydrocolloid dressing, compression dressings, all those particular stuff, right? Because in the keloid, what you need to understand, there is a high risk of recurrence. Okay, so what you have is a high risk of recurrence over here, and that is why you have to kind of do these particular things with the keloid. Okay, yes, okay, got it, great. Now let's move on to the next question. Now this is again a very important topic for you guys. So there's a lady with the varicose vein with an eczema, and the stage blah blah blah, clinical stage of this particular CAP classification. So what they're trying to tell you, that there is a varicose vein with the eczema. What is a C stage according to the CAP classification? So what is this? What do you think? What is the answer over here? Is it like the C2, C4A, C3, C4B? What is the answer over here? So what we're dealing with over here is a C4A. Okay, so this is what is the CEAP classification in the patients with the varicose vein. In the patients with the varicose vein, what do we have is, we have a CEAP classification. We have a CEAP classification. What does the C stands for? C basically stands for your clinical. What does E stands for? E stands for etiological. A stands for your anatomical, and P basically stands for pathophysiological. Okay, so this is what is the CEAP classification. Out of these, which is more important is the C. Okay, so the C stage in the CEAP classification, this is something which is more important. Okay, so let's kind of talk about this. Now I understand that you might be having some difficulty in understanding and remembering these particular things, but I'll just kind of tell you, and if you remember it like this, then you will understand that particularly in a better manner. So yeah, got it. Yeah, I'm taking it in a better manner. Okay, so let's assume that you and I, okay, you and I are basically the normal individuals at this point. We do not have any varicose veins. So what are we? We are the normal individuals. Okay, now what can happen is that its life. So we can develop something which is called as a reticular veins. Okay, so we may develop something which is called as a reticular veins or telangiectasias. Okay, so we can do that. Yeah, we can develop. So what do you understand by the reticular vein and the telangiectasia? So where the dilatation is less than 3 millimeters. Okay, so when the dilated veins are less than 3 millimeters in diameter, this is what is called as the reticular vein or the telangiectasia. Now, over a period of time, what we can develop is we can develop an asymptomatic varicose vein. So what we can develop is we can develop an asymptomatic varicose vein. We can develop that. That's fine. Now, once we develop this particular asymptomatic varicose vein, what is the first symptom? Like, let's say if at all there's somebody who is developing a varicose vein and it's not being treated in a better manner, what is the first symptom or the first things which are going to develop in these particular patients? The patients are going to develop edema. Patients are going to develop edema. Now, if at all, even at this stage, the things are not taken care of, what can happen is that the vessels, like the blood vessels, they can become more permeable, and what basically comes out of that is RBCs. RBCs basically come out. These particular RBCs are destroyed. Okay, so what happens? These particular RBCs are destroyed, and what you basically get is hemoglobin. What you get is a hemoglobin, and this particular hemoglobin is basically converted to what you call as a hemosiderin. Hemosiderin. Okay, and this hemosiderin is something which is responsible for skin pigmentation. So this is responsible for skin pigmentation and eczema. You understand my point? So please understand, there are many MCQs in this. So this hemosiderin is responsible for the skin pigmentation. It is not the hemoglobin. Okay, hemoglobin is converted to hemosiderin, and hemosiderin is the one which is basically responsible for the skin pigmentation and the eczema. Now the next thing is that WBCs can also come out, and these particular WBCs, they can get activated. There can be free radical activation and all those particular things, and this can lead to something which is called as a, so there can be what you call as a free radicals can kind of get activated, and all those particular things can happen, and because of this the patients may land up into lipodermatosclerosis. Okay, so patients may land up into lipodermatosclerosis. You understand my point? Lipo means fat, dermato means skin, sclerosis means sclerosis. Okay, so patients may land up into lipodermatosclerosis because of this activation of the WBCs and everything. Over a period of time, what can happen? The skin may become kind of weakened, and the skin kind of lose its quality and everything. And over a period of time, what can happen? The patients can develop ulcers. Okay, what can happen? The patients can develop ulcers, and these particular ulcers can be either a healed ulcer. Okay, it can be either a healed ulcer or it can be what you call as an active ulcer. It can be healed ulcer or it can be an active ulcer. Do you understand this point? So this is how the what you call as a disease of the varicose vein can kind of progress over a period of time, right? Now, if you have understood this, you will understand the CEAP classification. So what is this normal individual? This is what is a C1. C1 is basically the normal individuals. What is this reticular vein and the telangiectasia? That is, this is C0. Normal individuals is C0. Reticular vein and the telangiectasia is the C1. Asymptomatic varicose vein is C2. Edema is basically C3. Development of the skin pigmentation and eczema, that is what is a C4A. This lipodermatosclerosis is basically C4B. Healed ulcer is basically C5. And the active ulcer is basically C6. You understand my point? So if you have, it's very simple. This is how the patients of the varicose vein actually progress in their kind of a disease. And if you have understood that, you will understand the CEP classification. So what do we have? We have C0, we have C1, we have C2, we have C3, we have what you call as a C4A, we have this particular C4B, we have C5, and we have C6. So this is what is a C stage of the CEAP classification, clinical stage of the CEAP classification. I hope you have understood that particular point in a good detail. Okay, understood this, guys? Yeah, very important. Okay, yes or no, guys? Just give me a thumbs up. Do you want? All okay? Yeah, I hope you have understood this point. Okay, now let's move on to the next question. So which of the following statements is true regarding the suture material which has been shown in this particular image? Okay, so which of these particular statements is true? So what is being shown over here? we have a catgut kind of a suture. Okay, so what we have a catgut suture which has been shown over here. Which of the following statements is true? It is made up of the rapid kind of submucosa, made up of the cat submucosa, non-degradable, degraded with the enzymatic degeneration. So what is the answer over here? Can you please help me with this? Yeah, so the answer over here is D, that is, it is degraded by the enzymatic degeneration. Okay, so now let's talk about this particular suture materials. Okay, so what we have is, we have this particular needle. Okay, we have this particular needle, and what is attached to this particular needle is a thread. Okay, so what is attached to this particular needle is a thread. So what we are trying to talk to you about, we are trying to talk to you about this particular thread. Okay, so this is what is your suture material. So we are going to talk about this particular suture material. So what you need to understand about this particular suture material is that, okay, so what you need to understand about this particular suture material. So this particular suture material, what you need to understand, it can be either absorbable or it can be non-absorbable. Okay, so this absorbable suture material and the non-absorbable, they both can be either natural or they can be synthetic. Similarly, for the non-absorbable, it can be either natural or it can be synthetic. Okay, so what are the examples of the naturally occurring absorbable sutures? It is catgut, okay, and chromic catgut. What about the synthetically occurring absorbable sutures? They are basically vicryl, monocryl, PDS. Okay, these are the synthetically occurring absorbable sutures. Okay, then what about the naturally occurring non-absorbable sutures? You have silk. Okay, and what about the synthetically occurring absorbable sutures? You have nylon and you have proline. Okay, so these are the naturally occurring and the synthetic occurring absorbable sutures and the non-absorbable sutures. That is what you need to understand over here. Now let us talk about the naturally occurring absorbable sutures. That is what is your catgut. Okay, so from where is this particular catgut kind of derived? Can you please help me? So this is basically derived from the submucosa of the intestine of the sheep. Okay, so please try to understand, it is derived from the submucosa of the intestine of the sheep. Why submucosa? Why submucosa? Because this is the toughest layer. Okay, so this is the toughest layer of the intestine. Okay, so because this is the toughest layer of the intestine, this is basically derived from the submucosa of the intestine of the sheep. Okay, so I hope you have understood this point. Okay, now because it is derived from the intestine of the sheep, obviously it is a degradable kind of substance, right? So what you have to do is you have to kind of keep it in the preservative. So you have to keep it in the preservative. What is the preservative which you basically use for this? The preservative which you basically use for this catgut suture is isopropyl alcohol. Isopropyl alcohol. Okay, so isopropyl alcohol is the preservative which we are basically using for this catgut suture. Okay, now the problem with the catgut suture is about the absorption time. Okay, so what is an absorption time for the catgut suture? Can you please help me with this? What is a absorption time? What is an absorption time for the catgut suture? It is around 5 to 7 days. 5 to 7 days, and this absorption is basically happening by the enzymatic degeneration. Enzymatic degeneration. So what you need to understand is that wherever there is going to be the involvement of an enzymes, there's going to be an exothermic reaction. Okay, so wherever the enzymes are going to be involved, it is going to be an exothermic reaction. It is going to be an exothermic reaction, and whenever there is an exothermic reaction, what is going to happen? There's going to be a lot of tissue reaction. Okay, so what do you understand by this particular tissue reaction? That is that let's say if at all the stitches were taken at some place or something, okay, and after the absorption has kind of taken place, what you need to understand, if you kind of move your fingers about it, you will feel that there is some kind of an residual effects in the tissues. You understand my point? Now, if at all you kind of take this particular suture in some small lumen, it might cause the stenosis of that particular lumen. So that is why the importance of this enzymatic degeneration. Otherwise, why do we care why it is absorbed by the enzymatic degeneration or something else? So here it is basically absorbed by the enzymatic degeneration. It's an exothermic reaction leading to the tissue reaction. Okay, so yes, in order to increase this particular absorption time, we came up with the chromic catgut. And in the chromic catgut, what you need to understand is that the plain catgut was basically coated by the chromic acid. Okay, so chromic acid coating was done on the catgut. So this increased absorption time, that's fine, but the absorption time was not increased to 60 to 90 days or something like that. It was basically what you need to understand is that the absorption time was basically increased to around let's say 21 days to 28 days. It was not increased to 60 to 90 days. Okay, I hope you're able to understand. Okay, got it? Right. Okay, right. That's all you need to understand about the naturally occurring absorbable sutures. What about the synthetically occurring absorbable sutures? What are these synthetically occurring absorbable sutures? You have vicryl and the monocryl, and these are the ones which are absorbed by what? They are absorbed by the process of hydrolysis or phagocytosis. Hydrolysis or phagocytosis. And because they are absorbed by this particular process of the hydrolysis or the phagocytosis, because of this, the tissue reaction is very, very less over here. Now, the vicryl and the monocryl, they have the absorption time of around 60 to 90 days. Please try to understand this point. And this PDS, this is what is called as a delayed absorbable sutures. Absorbable suture, and this is the one which is going to have the absorption time of 180 days. Okay, so this is the one which is having the absorption time of around 180 days. Okay, so the absorption time of the vicryl and the monocryl is basically around the absorption time of the vicryl and the monocryl is basically around 60 to 90 days, and the absorption time for your what you call as the PDS is around 180 days. That is what is called as a delayed absorbable sutures. Okay, I hope you're able to understand this particular point, right? So is my volume okay? Everybody is okay with my volume? Anybody else is facing this particular lag problem, or is it like just who is facing this particular lag problem? Everybody's okay with this particular, like, is there any lag problem with you guys as well? So if yes, please let me know. Or is it like only facing with one particular person? Okay, if at all there is any problem, just let me know in the comment box, guys. Okay. Though I think the internet on your end has to be kind of corrected a bit, I guess. Okay, yeah, that's fine. Okay, so the following ulcers is seen in which condition? So you have this particular image in front of you. This particular ulcer is basically seen in as a malignant ulcer, arterial ulcer, venous ulcer, trophic ulcer. What do you think? What is the answer over here? The answer over here is an arterial ulcer. So what you have is, you have a punched out kind of looking ulcer which is basically present on the lateral aspect of the leg. Okay, so what is this? This is what is a like a punched out kind of looking ulcer which is basically present on the lateral aspect of the leg. So let's talk about the arterial ulcers. Arterial ulcers. So these arterial ulcers, what you need to understand, they are basically your punched out ulcers. So these are obviously, they are the punched out ulcer. If I ask you what is the most common site of this, what is the most common site of these particular arterial ulcers? The most common site of these particular arterial ulcers is the lateral aspect of the leg, or what you call as the tip of the toe and fingers. Okay, so the tip of the toes and the fingers, these are the most common site for the development of the arterial ulcer. Okay, yeah, I hope you're able to understand this point. Okay, so the lateral aspect of the leg and the tip of the toes and the fingers, so these are the most common site of your arterial ulcers, punched out ulcers. Okay, I hope you have understood. Now, what about the venous ulcers? What about the venous ulcer? Do I have the image of that? Okay, what is this? What is this? This is what is the characteristic image of your venous ulcer. Okay, so let's talk about the venous ulcers. Now, in the venous ulcers, what are you going to have is that there is going to be a sloping edge. Okay, what is there? There is a sloping edge, And if I ask you what is the most common site for the venous ulcer, it is the gaiters area. Okay, what is it? It is the gaiters area. So what is this particular gaiters area? This is medial side of the leg, lower 1/3. Okay, lower 1/3 of the leg on the medial side. So this is what is your gaiters area. Are you understand my point? So venous ulcers are basically present on the medial side of the leg, lower 1/3. This is what is the gaiters area, and this is what is the characteristic image which you're basically seeing in the venous ulcer. Okay, I hope you're able to understand sloping edges and everything. Okay, got it. Now what else you need to understand over here? So what about this particular chronic ulcer or the malignant ulcer? So if at all, this is a very, very important clinical scenario, that assume that they give you that there's a patient who is basically having a chronic non-healing ulcer. Non-healing ulcer. So for what is this particular chronic? Chronic basically means that more than 3 months. Okay, so more than 3 months have happened and the ulcers are not healing only. Okay, so if I ask you what is the next step in this particular patient? Okay, so what is going to be the next step in this particular patient? The next step in this particular patient is going to be your biopsy. Okay, so what is the next step going to be? The next step is going to be the biopsy. Why? What is the reason why the next step is basically going to be the biopsy? The next step is going to be the biopsy because you want to kind of rule out malignancy. What malignancy can happen in these particular patients? So you have to basically rule out what you call as a Marjolins ulcers. Marjolins ulcer. So what is this particular Marjolins ulcer? When you that chronic non-healing ulcer, what you have to do is you have to kind of do a biopsy. Which biopsy? So this is what is called as an edge or a wedge biopsy. Okay, so what you have to basically perform is an edge or a wedge biopsy, and yeah, that is why you want to perform this, because you want to rule out this particular Marjolins ulcer. And what is this particular Marjolins ulcer? What is the histopathological diagnosis of this? So on the histopathology, what you're going to find is a low grade squamous cell carcinoma. So what you're going to find? You're going to find a low grade squamous cell carcinoma. Are you understanding my point? A low grade squamous cell carcinoma, this is what you're basically going to find in the chronic non-healing ulcers. Okay, that is what you have to kind of rule out on the edge or the wedge biopsy. Okay, so this is what you need to understand, very, very important. Okay, so these are the important things about the ulcers which you need to understand. Now it's again important kind of a clinical scenario. They might give you that there is a small baby around 11-12 months or something was brought to the emergency with an abdomen pain in the abdomen is there, and this particular pain in the abdomen is basically colicky type of a pain. What do you understand by the colicky pain? Colicky pain. Colicky pain basically means that the intensity of the pain basically increases and then it basically comes down. Okay, so colicky abdominal pain is basically indicative of your intestinal obstruction. Okay, so this is what is an indication of your, this is indicative of your intestinal obstruction. So here there's an 11-month-old child who has been brought to the emergency with the pain in the abdomen, and there is also the multiple episodes of vomiting. On examination, there is a mass which is palpable in the right lumbar kind of a region. Bare minima has been given below. This is the image. What are you basically seeing on the screen is your bare minima. What is the diagnosis? Yeah, definitely the diagnosis over here is an intussusception. Okay, so what is the intussusception? What is this intussusception? Intussusception is a condition where a part of the bowel is basically telescoping into the other. So here what is happening? The part of the bowel is telescoping into the other part. It means that let's say there's one part of the bowel which is basically telescoping into the distal part of the bowel. This is what is referred to as an intussusception. You understand my point? So this is what is referred to as your intussusception. Now what is the most common kind of like where does it occur? So it basically occurs in the children. Okay, and what is the most common type of that? So what we have is the ileocolic. What do you understand by the ileocolic? That is, the ileum is basically going into the colon. So this is what is an ileocolic type, and that is what is the most common type of your intussusception. Okay, so I hope you are able to understand this point. Okay, now on clinical examination, what are you going to find? Okay, so on clinical examination, what are you going to find? On clinical examination, on clinical features of these particular patients, yeah, you're going to have a colicky abdominal pain. Abdominal pain is going to be there. The patients may also have something which is called as a red currant jelly stool. Okay, so what the patients may have is a red currant jelly stool. That can also happen in these particular patients. Red currant jelly stool, they can come. Now, when we talk about the diagnosis, okay, so when we talk about the diagnosis, how you can make the diagnosis of these particular patients. So what are the different things which you have for the diagnosis? So you can do an ultrasound. What are you going to find on an ultrasound? On the ultrasound, you can find a target sign, or you can find a pseudo kidney sign. Okay, so this image is very, very important for you guys. Okay, so please understand, this is what is an image of an ultrasound which is showing a target sign or a donut sign. Okay, so this is what is a target sign or the donut sign which you basically see in the patients with an intussusception. This is what is a pseudo kidney sign. It appears as if it's like a kidney, right? So like if at all you keep the probe of your kind of ultrasound what you call in like perpendicular to the particular bowel, then you are going to get the target sign. But if at all you keep the probe of your ultrasound along that particular bowel, then what you're going to find is the this kidney sign, pseudo kidney sign. Okay, so that's what you need to understand. Now, when you perform a barium enema, what are you going to find in the patients with the barium enema? Can you please help me with this? On the patients with the barium enema, what are you going to find? In the patients of the barium enema, you're going to find a claw sign, or you're going to find a coiled spring appearance. Okay, so what you're going to find? You're going to find a claw sign or a coiled spring appearance. Please try to understand this particular point. Okay, a claw sign or a coiled spring appearance, this is what you're going to find in the patients in the barium enema. Okay, so please try to understand this point. Okay, and when let's say you have a patient of a like on the plain x-ray, okay, plain x-ray, what you're going to find on the patients with the plain x-ray, over here you're going to find an air crescent sign. Okay, so what you're going to find is a air crescent sign on a plain x-ray. I hope you are able to understand this point. These are all the important signs which you basically have over here. So this is what is a characteristic claw sign which you basically get in the patients with the barium enema. Okay, now what about the management? How do you manage these particular patients? Okay, so what about the management of the patients with this particular intussusception? If at all there is no peritonitis, no features of peritonitis. What are the features of the peritonitis? Rigidity, guarding. Okay, so if at all there are no features of the peritonitis, then you have to kind of perform an, let's say, air enema. Okay, or let's say what you call as a yeah, so gastrographin enema, enema. Okay, so you have to kind of reduce the bowel with the help of the air enema or the gastrographin enema or something like that. Okay, I hope you're able to understand this point. But if at all the features of peritonitis are present, okay, if at all the peritonitis is present, okay, if at all the peritonitis is present, then you have to kind of perform a surgical resection and anastomosis. I understand my point. Then you have to basically perform a surgical resection and anastomosis if at all the features of the peritonitis are present. Okay, I hope you are able to understand and appreciate these particular points, guys. Okay, now let's say there is a 55-year-old patient presented with the emergency with the scrotum swelling, ecchymosis, fever, and the serous discharge, and the image has been kind of given below. What is the most probable diagnosis? And this is very, very important. Now I basically see this particular question practically in every FMGE exam. So what is the diagnosis over here? What is the kind of a diagnosis over here? Yeah, I'm pretty sure that all of you guys know this. What you're dealing with, you're basically dealing with the Fournier's gangrene. Okay, so what is this? This is what is the Fournier's gangrene. If not, any one of you who is going to kind of appear for the FMGE exam and you have never seen this particular image, please understand what is this. This is what is the Fournier's gangrene. Okay, so this is what is the Fournier's gangrene. So let us talk about the Fournier's gangrene in detail. Fournier's gangrene. So what about this particular Fournier's gangrene? What you need to understand about this particular Fournier's gangrene, that this is what is called as a necrotizing fasciitis of the subcutaneous tissue. Okay, so what is this? This is what is a necrotizing fasciitis of the subcutaneous tissue. Now, if I ask you which is the most common organism which is associated with this, so we have anaerobic organisms like Clostridium. Okay, anaerobic organisms like the Clostridium, these are the ones which are most commonly. Along with that, even the aerobic organisms may also be kind of involved over here. So many times what you have is a polymicrobial. Polymicrobial. You understand my point? So what you have is a polymicrobial. Anaerobic organisms, yes, they are there. Along with that, aerobic organisms are also kind of involved over here. So what we have is a polymicrobial. Okay, polymicrobial organisms is kind of there. Okay, right? Okay, yeah, that's all fine. Most common organism, blah blah blah, all these particular things is fine. Now, how are we going to, so what are important is they ask you what is the most common organism, anaerobic, but polymicrobial can be there, that's fine. The image is very important. And finally, what about the management? How do you manage these particular patients? It is debridement. Okay, so you have to go ahead with a debridement, that you have to kind of remove all the dead necrotic tissue and everything. You have to kind of just kind of keep on removing it. Okay, but the important thing is about the testes. Okay, testes, do you remove it? Do you remove it? Do you remove the testes? The answer is no. It's a big no. Why do you not remove the testes? You do not remove the testes because the blood supply of the testes is basically coming from the aorta. You understand my point? So the testes, they receive the, so here what you need to understand, the testes are viable. Okay, so the testes are viable. Why? Because they receive the blood supply. They receive the blood supply from the aorta. Okay, they receive the blood supply from the aorta and they are viable. I hope you're able to understand this point. Okay, that is what you need to understand over here. So you kind of debride, you kind of remove all the dead necrotic tissue and everything, but I hope you're able to understand that these particular testes, they are viable in these particular patients. So this is again important. After the debridement, this is how it basically looks like. Okay, now let's move on to the next question. So the laboratory investigations were performed, and what you find was that there is a patient who is having jaundice and who is having elevated ALP levels. Okay, so there's a patient who is having jaundice and there's a patient who is having elevated bilirubin and whatever the alkaline phosphatase levels are kind of elevated. The rest, all the liver enzymes are basically normal. And what is the diagnosis of this particular patient? So can you please help me with this? What is the diagnosis? So it's one of the most simplest questions over here. So there's a jaundice, there's a patient who are having an elevated bilirubin and there is an elevated alkaline phosphatase. So this is what is basically a marker of your obstructive jaundice. Okay, so what is this? This is what is a marker of your obstructive jaundice. Okay, so I hope you are able to understand this point. Okay, so what is this? This is what is your obstructive jaundice which you are dealing with over here. Okay, obstructive jaundice. Understood? Right. Now let's move on to the next question. There is an elderly female who had a history of a hysterectomy 3 years back, and that's completely irrelevant what they have given over here. That is not of any relevance, but yeah, they have given it. So let's kind of understand it. Okay. Now, the patient had a colicky abdominal pain and the bilious vomiting. So there's a female who is having a colicky abdominal pain and the bilious vomiting. On examination, there is a tenderness of the abdomen and an increased peristalsis. The X-ray basically revealed that there is an air inside the biliary tree with the multiple air fluid levels. Okay, so I hope you're able to understand this point. This is what is given to you. Okay, now this is a very, very important clinical scenario. Please kind of make a note of this. Okay, so what they have given you, that there is a female, okay, and what they have given you, that there is a patient who is having a colicky abdominal pain. Colicky abdominal pain. Okay, so there is a colicky abdominal pain which is there. Along with this, there's a patient who is having a bilious vomiting. Bilious vomiting is there. Okay, then what else? There is tenderness in the abdomen. Tenderness is there. Along with that, there is an increase in the peristalsis is there. Okay, so when you auscultate, there is an increased peristalsis, hyperkinetic peristalsis are there, all this particular stuff. The X-ray basically shows that there is an air in the biliary tree. Okay, there is a air in the biliary tree. Okay, so that is what you need to understand. And there are multiple air fluid levels. Air fluid levels. Okay, so there's a female who is having a colicky abdominal, that's fine. Bilious vomiting. So all these particular things are basically pointing towards an intestinal obstruction and air in the biliary tree and multiple air fluid levels. Okay, so what is the diagnosis? Yeah, so I guess you guys have already told quite a lot of times. So this is what is the gallstone ileus. Now let's try to understand what is this particular gallstone ileus. Okay, so let's try to understand about this particular gallstone ileus. Gallstone ileus. What do you understand by ileus? Ileus basically means obstruction. Okay, so any obstruction which is basically caused because of the gallstone, that is what is referred to as your gallstone ileus. What happens in these particular patients is, let's assume that this is a gallbladder and let's assume that this is the intestine. So what happens is that, let's say there is a stone which is basically present inside the gallbladder. Now, due to some or the other reason, what can happen is that this particular stone can erode through the wall of this particular gallbladder. Okay, so what it can do, it can erode through the wall of this particular gallbladder. Okay, it can do that. It can erode through the wall of the gallbladder and then it can come inside the intestine and then it can lead to some kind of an obstruction distally. So this is what is the pathogenesis of the gallstone ileus. Okay, so please try to understand this point. Everybody understood what is happening? That there is a gallstone which is eroding through the wall of the gallbladder, entering into the intestine, and that is going distally and it is causing an obstruction. So the important questions which they ask you over here is that what is the most common site of obstruction? What is the most common site of obstruction in these patients in gallstone ileus? In gallstone ileus, what is the most common site of obstruction? So please try to understand. The answer over here is just proximal to the ileocecal junction. It is not at the ileocecal junction. It is just proximal to the ileocecal junction. Please try to understand this point. Okay, so the most common site of the obstruction is just proximal to the ileocecal junction. Okay, I hope you are able to understand this particular point. The site of the obstruction is just proximal to the ileocecal junction. Okay, now yes, absolutely right. As somebody is trying to tell us that, you know what, in these particular patients, what you basically end up having is a Regular's triad. So what is this particular Regular's triad? Regular's triad is basically a combination of what you call as a intestinal obstruction. Along with that, what you have is a pneumobilia. What do you understand by the pneumobilia? Pneumobilia basically means that there is air in the gallbladder, and along with this, what you have is an ectopic gallstones. So this is what you need to understand over here. What you basically get is a Regular's triad. What is this Regular's triad? So this is the combination of the intestinal obstruction with the pneumobilia, that is air in the gallbladder, and the ectopic gallstone. So these three things together, this is what is called as a Regular's triad. So Regular's triad is basically seen in gallstone ileus. They keep on asking you this. Okay, so yeah, that's what you need to understand. This is all about the gallstone ileus, which you need to understand and remember. Now let's try to understand this particular concept. There's an elderly patient with an inguinal hernia which is medial to the what you call as internal iliac inferior epigastric artery. So there is a inguinal hernia which is medial to the inferior epigastric artery. What is the diagnosis over here? And what is the management of choice? So first of all, what is the diagnosis? And the second of all, how are you going to manage these particular patients? So this is what they're trying to ask you over here. So what is the diagnosis and how are you going to manage these particular patients? Can you please help me with this? Okay, so this is, they are basically trying to test you on the basis of what is called as your Hasselbalch's triangle. So what is this particular Hasselbalch's triangle? Hasselbalch's triangle is basically a triangle which is basically formed between your rectus abdominis muscle. So this is what is your rectus abdominis muscle. Then what we have this particular inguinal ligament over here, and then what we have is an artery. So which is this particular artery? This is your inferior epigastric artery, and we have an inguinal ligament. And then what we have a deep inguinal ring. We have a deep inguinal ring, and then we have a superficial inguinal ring. What they have given you, that there is a hernia which is coming out from this particular triangle. Okay, so they have given you that the hernia is basically coming medial to this inferior epigastric artery. So if at all there is a hernia which is coming medial to this inferior epigastric artery, what you need to understand is that this is what is your direct inguinal hernia. So what you need to understand, this is important. Okay, so this triangle which is formed between these things, this is what is called as an Hasselbalch's triangle. What is it called as? It is called as an Hasselbalch's triangle. Okay, so now what you need to understand over here, that if at all there's a hernia which is coming through this particular okay, so if at all there is a hernia which is coming medial to the inferior epigastric artery. This is what is referred to as your direct inguinal hernia. What is this? This is what is your direct inguinal hernia. And if at all there is a hernia which is coming lateral to the inferior epigastric artery, this is what is your indirect inguinal hernia. Okay, so this is what is your indirect inguinal hernia. Are you understand my point? So hernia which is basically medial to the inferior epigastric artery, direct inguinal hernia which is lateral to the this particular inferior epigastric artery, this is what is your indirect inguinal hernia. Okay, so let's come back to the question. So elderly patient inguinal hernia which is medial to the inferior epigastric artery. So what is the diagnosis? The diagnosis over here is a direct hernia. What is it? It is a direct hernia. And how do you manage these particular patients? You manage it with the Lichtenstein repairs. What is this Lichtenstein repair? This is what is called as a hernioplasty. What do you understand by hernioplasty? Hernioplasty basically means the mesh repair. What is this? This is what is a mesh repair. Okay, so with the help of a mesh, you repair a hernia. This is what is called as a hernioplasty. And what is the mesh which you're using in this particular stuff? So which you're basically using is a Prolene mesh. Okay, so what you're using is a Prolene mesh. Okay, so Prolene is the mesh which is basically used in these particular patients. So Prolene mesh is used. That is what is called as a hernioplasty. What is this Bassini's repair? What is this particular Bassini's repair? Bassini's repair is what is called as a herniorrhaphy. Okay, what is this? Herniorrhaphy. Herniorrhaphy means that with the help of a suture, you are kind of repairing the hernia. So this is what is called as a herniorrhaphy. In the herniorrhaphy, you do not use kind of the mesh. You basically use like with the help of the sutures, you kind of repair it, which is better. So in today's time, most of the times we just perform this hernioplasty only. Okay, so herniorrhaphy is obviously not good because it causes what you call as a tension. It causes a tension. That is what you need to understand over here. Okay, so yeah, I hope you're able to understand this particular point. Okay, right? Okay, so yeah, these are the things which you need to understand over here. Okay, got it. Now let's move on to the next question. There's a middle-aged man who complains of an upper abdominal pain after the heavy meal. There's a tenderness in the upper abdomen, and the X-ray. There's a widening of the mediastinum is seen with the pneumomediastinum. What is the diagnosis? So here, what you need to understand is there is a kind of a male is there who is okay. There's an upper abdominal pain. So there's an upper abdominal pain happens after the heavy meal, after a lot of food is eaten. There's a tenderness in the upper abdomen, and the X-ray is basically showing the widening of the mediastinum, and it seems to have a pseudomediastinum, like pseudomediastinum, pneumomediastinum as well. There's an air inside the kind of thoracic cavity. What is the diagnosis of this particular patient? So the diagnosis of this particular patient is a spontaneous perforation of the esophagus. Okay, what is it? It is a spontaneous perforation of the esophagus. Okay, so that is what is the diagnosis of this particular patient. Okay, so I hope you have able to understand this point. Okay, so this is very important concept. Let's kind of talk about this. This is not the ideal way in which they kind of give this particular question, but let's try to understand this point. Okay, so let's assume that there is a patient who has kind of taken alcohol. Usually alcohol is kind of given in the options, like in the clinical scenario, but alcohol is not kind of mandatory for this particular things to happen. So what we are basically discussing, the Boyer-Heave syndrome and the Mallory-Weiss syndrome. That is what we are kind of trying to discuss over here. So alcohol is usually given in the clinical scenario, but it is not mandatory. Okay, so let's assume that there is a patient who is kind of ingesting the alcohol. After that, let's assume that there is a vomiting. Okay, so there is a vomiting which is happening against the closed glottis. Okay, so what is happening? There's a vomiting which is happening against the closed glottis. Okay, so the glottis is closed and the patient is basically vomiting. Okay, so patient ingested alcohol, there is a vomiting against the closed glottis. So if at all there is a vomiting occurring against the closed glottis, what is going to happen? There's going to be the increase in the pressure. Okay, there's going to be the increase in the pressure in the esophagus. Okay, so there's going to be the increase in the pressure inside the esophagus, Okay, there's going to be increase in the pressure inside the esophagus, and this particular pressure increase in the esophageal pressure has to kind of give away in one way or the other. So because of this, if at all, it leads to what you call as a through and through rupture of the esophagus, it means that is the esophagus is completely kind of ruptured. That is what is referred to as your Boyer-Heave syndrome. What is this? This is what is your Boyer-Heave syndrome. So what is this Boyer-Heave syndrome? Boyer-Heave syndrome is that there is a through and through rupture of the esophagus. That is what is called as the Boyer-Heave syndrome. And if at all, let's say there is what is called as a longitudinal tear. Okay, so if at all there is a longitudinal tear of the mucosa. Okay, so this is what is referred to as your what is called as a Mallory-Weiss tear. Okay, this is what is called as a Mallory-Weiss tear. What is a Mallory-Weiss tear? Mallory-Weiss tear is basically the longitudinal tear. So in the Mallory-Weiss tear, what happens? The patients basically develop the bleeding. So bleeding is what is basically happening in the Mallory-Weiss tear. In the Boyer-Heave syndrome, that is what is your perforation of the esophagus. I hope you are able to understand. These are very, very important, guys. Okay, so this clinical scenario is very, very important. So the important thing is, yeah, alcohol is usually given, that's fine, but there's a vomiting against the closed glottis. Glottis is closed because of this increase in the pressure, and if at all this leads to your through and through rupture of the esophagus, that is what is the Boyer-Heave syndrome. And if at all there is a longitudinal tear of the mucosa, that is what is referred to as your Mallory-Weiss tear. Okay, I hope you are able to understand this particular point. Okay, now which of the following structures is not removed in the radical neck dissection? Sternocleidomastoid, inferior vena cava, accessory nerve and the carotid artery. No, it should not be the inferior vena cava. It's not should not be IVC. This should be IJV, internal jugular vein. Okay, so sternocleidomastoid, internal jugular vein, accessory nerve, and the carotid artery. So obviously the answer over here is a carotid artery. Okay, so what are we talking about? We are basically talking about the neck dissection. Okay, so there are two types of neck dissection. What we have is a radical neck dissection, and we have a like a modified radical neck dissection. So first let's talk about the radical neck dissection. Okay, so what we have is a radical neck dissection, we have a modified radical neck dissection. In the radical neck dissection, what are the things which we remove? So here we remove the lymph node stations 1 to 5. Along with this, what else do you remove? Along with this, you remove the spinal accessory nerve. SAN basically stands for your spinal accessory nerve. You remove what you call as, along with this, what you remove? You remove the internal jugular vein, which is your IJV, internal jugular vein. Okay, along with this, what else you remove? You basically remove the spinal accessory nerve, internal jugular vein, or along with this, you remove the sternocleidomastoid muscle. Sternocleidomastoid muscle. Okay, so these are the three things which you basically remove in the radical neck dissection. Are you understanding my point? So radical neck dissection per se is a very, very comorbid procedure. This is a very comorbid procedure. Are you understanding my point? It is a very comorbid procedure, and these are the things which you basically remove in the radical neck dissection. Okay, now because it is a very comorbid procedure, all these particular things are being removed and everything. So because of this, the patients were having a lot of problems and all. Okay, and that is why we came up with something which is called as a modified radical neck dissection. Okay, so what we came up with? We came up with a modified radical neck dissection. Okay, and this particular modified radical neck dissection, what you need to understand over here, that this is of 3 types. Okay, this is of 3 types. So what are the 3 types of this particular modified radical neck dissection? So we have type 1, type 2, and type 3. Okay, so there are 3 types of this particular modified radical neck dissection. What are these particular 3 types? In the type 1, okay, so in all these particular three, we are going to remove the lymph node stations from 1 to 5. Okay, this is basically removed in all. Okay, but in the type 1, what is the unique? In the type 1, we preserve the spinal accessory nerve. It means that the sternocleidomastoid and the internal jugular vein is kind of removed, but we preserve the spinal accessory nerve. In the type 2 modified radical neck dissection, what we do is we preserve spinal accessory nerve plus the internal jugular vein. So we preserve the spinal accessory nerve and the internal jugular vein. Both these particular things are kind of preserved. In the type 3 modified radical neck dissection, what we do is we preserve spinal accessory nerve plus internal jugular vein plus the sternocleidomastoid muscle. So we preserve all the three structures. So all the three structures are basically preserved in the type 3 modified radical neck dissection. In the type 2 modified radical neck dissection, we preserve the spinal accessory nerve and the internal jugular vein. And in the type 1 modified radical neck dissection, we preserve the spinal accessory nerve. I hope you are able to understand these particular things. It is very, 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 very important. Okay. So yeah, understood, right? I hope you have understood this point. Okay. Now let's move on to the next question. There is a 40-year-old male patient who is having a pet dog, okay, in his room, and he is presenting to the hospital with the pain in the right upper abdomen. On evaluation, there is a loculated collection was found inside the liver. Which of the following is likely organism implicated in this particular pathology? So yeah, what is the answer over here? Can you please help me with this? So here what you're dealing with is an hydrated cyst. Okay, so what is this? This is what is an hydrated cyst, and this is basically caused by your echinococcus granulosus. Okay, so echinococcus granulosus is okay. So what are the hints which are basically given in this? It's not an E. coli, Dr. Ishan. Okay, obviously because E. coli nahi hoga na, because pet dog. Why they give this particular pet dog? Because dog is the definitive host of this. Okay, so let's talk about this hydrated disease of the liver. Okay, hydrated cyst of the liver. Okay, so what is the organism which is associated with this? What did I tell you? Echinococcus granulosus. Okay, so this is the organism which is associated with this. If I ask you about the definitive host of this particular stuff is the dog, and the intermediate host is basically what you call as a sheep. Okay, so the definitive host is the dog and the intermediate host is basically the sheep. Okay, so that is what cattle is. Okay, so man is basically an accidental host in this. Okay, so what is a man? Man is basically an accidental host. Okay, so that's what you need to understand over here. Okay, now here what are you basically seeing? This is what is a lily sign. Okay, so this is what is a water lily sign. This is what you basically have in the ruptured hydrated cyst of the liver. Okay, so this is the ruptured hydrated cyst of the liver. Now this is an important image, guys. Okay, what are you basically seeing over here? This undulating membrane inside that particular cystic cavity. This is what is called as a so water lily sign. That is what is basically seen in the ruptured hydrated cyst of the liver. Okay, I hope you have understood this particular point, guys. Okay, now if I ask you about the investigation of choice, how are you going to diagnose these particular things? So there are two things. Okay, so investigation of choice to diagnose this particular hydrated cyst of liver. If I ask you overall, what is the investigation of choice? Overall, the investigation of choice is your serology. In this, what you have to perform is an ELISA, and in the ELISA, what you basically get is a characteristic ARC5 appearance. Okay, so characteristic ARC5 appearance which you basically get in the ELISA, that is what is a investigation of choice overall. Okay, overall the investigation of choice is your ELISA. What you basically get over there is an ARC5. Okay, now what about the other things? So if I ask you what about the radiological investigation of choice? Okay, so if I end up asking you what is the radiological investigation of choice? Okay, so in the investigation of choice, if I ask you what is a radiological investigation of choice, then what is going to be answer? So please try to understand, it is not ultrasound, guys. Okay, it is a CECT, contrast enhanced CT scan. Okay, contrast enhanced CT scan is the radiological investigation of choice which you get in these particular patients. Okay, so contrast enhanced CT scan is the radiological investigation of choice for the patients with hydrated cyst. Now, what is the treatment? How do you manage these particular patients? The management of these particular patients is by the pair technique. So what is this pair technique? Pair is basically puncture. Then A is for aspiration. So whatever the hydrated fluid and the scoliosis and all those daughter cysts are there, you basically try to aspirate it, because the hydrated fluid is basically highly immunogenic, because if it kind of comes in contact with the blood, the patients may land up into anaphylactic reaction. So you have to aspirate it. Then what you have to do, you have to inject. What do you have to inject? You have to inject the scolicidal agents. Scolicidal agents. What do you understand by the scolicidal agents? So these are the agents which are basically going to kill the what you call as the daughter cysts. Okay, so whatever the trophozoites and everything, they are basically going to kill those particular stuff, right? So what are the scolicidal agents which we have? So we have what you call as a 20% hypertonic saline, then cetrimide, formalin. Okay, all these are what you call as a scolicidal agent. So you basically inject these particular scolicidal agents into this particular hydrated cyst. Okay, then what you do, you basically re-aspirate. Okay, so what you do is you re-aspirate. Okay, so I hope you're able to understand. You puncture, you aspirate, you inject, and then you re-aspirate. So this is what is called as a pair technique. What is this? This is what is called as a pair technique, which is basically used for the treatment of your hydrated cyst. Okay, for the hydrated cyst, what you basically have is this particular pair technique. Understood? I hope you have understood this particular point, guys. Yep. Okay, now yeah, let's talk about the next question now. Okay, now this is again a very simple but an important question for you guys, because they keep on asking you these kind of stuff. So a 28-year-old, let's say the pregnant woman, presents with a history of a kind of a decreased fetal movements, respiratory distress in her newborn. So the newborn is born and the child is basically having this particular respiratory distress and this particular stuff. On examination, the neonate appears cyanotic and there is an increased work of the breathing. So there's a cyanosis and the patient is basically, like the infant is basically having difficulty in breathing. Okay, formalin is, no, so it is a scolicidal agent. It's not commonly kind of a use. It is not commonly used, but yes, it is a kind of a scolicidal agent. So KK, yes, it is a scolicidal agent. Okay, it is not very commonly used. The most commonly used scolicidal agent is this 20% hypertonic saline. Okay, so that is what is kind of most commonly used. Okay, right. So over here, what you need to understand, yeah. So on auscultation, there was a revealed the bowel sounds are basically present in the what you call it, the left hemithorax, and the chest X-ray is kind of given in the following image. Which of the following congenital anomalies is most likely responsible for this particular condition? And as most of you have told me already, it is a congenital diaphragmatic hernia. Now just look at this particular image, and this is very, very important. So what you need to understand over here, that the parts of the intestine have basically gone inside the thoracic cavity. Are you able to appreciate this point? So these are the parts of the intestine which have kind of gone into the thoracic cavity. So the intestines have kind of gone up into the thoracic cavity, and this is what is referred to as your congenital diaphragmatic hernia. Okay, so this is what is referred to as your congenital diaphragmatic hernia. Okay, I hope you are able to understand this particular point. Got it? Okay, now yeah, so let's talk about this. So what is the congenital diaphragmatic hernia? So this is what is called as a Bogdalex hernia. Bogdalex hernia. What is this particular Bogdalex hernia? This is basically present because of the defect in the posterolateral defect, which is more on the left side as compared to the right. Okay, so the numeric for this, what you can remember is BPL. What is this BPL? Bogdalex hernia, posterior lateral defect, more on the left side. Okay, so you can just remember this particular mnemonic. Bogdalex hernia is a posterior lateral defect on the left side. Okay, so here what happens is that because there is a defect inside the diaphragm, the parts of the intestine are basically going up into the thoracic cavity. They're pushing the lungs towards the opposite side, and that is why when the child is born at birth, the child is basically having a respiratory distress. Okay, so what the child is having a respiratory distress at birth. Okay, now here what you need to understand is a couple of things. Bag and mask ventilation. Where are you going to do this? Bag and mask ventilation. Are you going to do this? So bag and mask ventilation is basically contraindicated in these particular patients. Okay, so bag and mask ventilation is contraindication indicated over here. Okay, right? Okay, now that's all fine. Most common cause of mortality in these particular patients is pulmonary hypoplasia. Because the intestines are basically present inside the thoracic cavity. They do not allow the lungs to kind of develop in a proper manner. So the lung development is a problem over here. So because the kind of the what you call as the intestines are basically present inside the thoracic cavity, the lungs will not be able to develop in a proper manner, and because of this what is going to happen that the patients are basically going to have what you call as pulmonary hypoplasia, and this is what is the most common cause of mortality in these particular patients. I hope you're able to understand this particular point, guys. Okay, now yeah, that's fine. So which of the following is the common complication of an ERCP? Okay, so yeah, can you please tell me which of the following is the common complication for an ERCP? Yeah, which of the following is the common complication for the ERCP? Can you please help me with this, guys? So answer over here is what you refer to as a cholangitis. No, the answer over here is an acute pancreatitis, guys. Now, why I waited for your answers, guys, is because this was the thing which was recently asked to you. Like in the last FMGE exam only, they asked you that what is the most common complication of your ERCP. The answer over that is acute pancreatitis. Okay, acute pancreatitis. So around 5% of the patients with the ERCP, they have what you call as okay. So I hope you're able to understand. Okay, so the most common complication of an ERCP is what you call as an acute pancreatitis. This is basically present in 5% of the patients who are undergoing an ERCP. 5% of the patients undergoing ERCP, what you basically have is this acute pancreatitis. Okay, so that is what is ERCP? ERCP is intrahepatic cholangiopancreatography. That's what you need to understand. Most common complication is your acute pancreatitis. Now, which out of the following have a maximum chance of graft versus host rejection? Okay, so which has the maximum chance for your graft versus host rejection? So here the answer over here is an intestine. Okay, why the answer is over here intestine? Because what is the graft versus host rejection? That is, the graft has what you call as the T cells, and these T cells of the graft, they basically attack the recipients. Okay, so T and B cells of the graft, they basically attack the recipient. So the intestine that has a lot of lymphoid tissue. So this graft versus host rejection is common when the what you call as the transplanted organs, they have a lot of lymphoid tissue inside them. You understand my point? So when they have a lot of lymphoid tissue inside them, then they can lead to this particular graft versus host rejection. So out of all these, indirectly what they are trying to ask is that which of these organs they have a more amount of a lymphoid tissue. The answer over here is an intestine. We do understand that pairs, patches and other things are there. So yeah, the answer over here is an intestine. So I hope you have understood, and I hope you have understood what is a graft versus host rejection. That is, the T and the B cells of the graft, they start attacking on the kind of the recipient. Why? Because the recipients are immunosuppressed. So these T and B cells, they can basically attack the recipients, and the management of that is to reduce the immunosuppression. So the dose of the immunosuppressive agents, they have to be reduced in order to manage this graft versus host rejection. Okay, understood? Right. Now there's a patient who was recently operated with a laparotomy was done, and the patient developed the complications after the operation. What would be the surest sign of the wound dehiscence? Now this is again a very, very important kind of a question. Surest sign of the wound dehiscence. What is this? What is this? Is it like the increased vowel sounds, peristalsis, like the persistent abdominal pain, serosanguinous discharge from the wound, or widening of the abdominal scar with the palpable edges? Okay, so what do you think? What is the answer over here? See guys, the answer over here is definitely a serosanguinous discharge from the wound. Okay, what is the answer over here? It is a serosanguinous discharge from the wound. Now this is a very, very, very important topic. So let's talk about this. Okay, so what do you understand by the wound dehiscence or the burst abdomen? Okay, so what is this? This is what is your burst abdomen or the wound dehiscence. Okay, so what is this burst abdomen or the wound dehiscence? What do you understand by this? Okay, so what you need to understand is that when you do a laparotomy and after the laparotomy kind of wound is closed, what you do is you kind of close the sheath of the abdomen, you kind of close the muscles, you kind of close the subcutaneous tissue, you close the skin. So all these particular things you basically close in the layer-wise layer. So after the laparotomy, what you need to understand is that the layers of the abdomen, like the abdomen is basically closed in multiple layers. So what you need to understand is that abdomen is closed in multiple layers. Okay, so what you need to understand is that when do you say that the patient is basically having a burst abdomen? If the sheath of the abdomen is basically giving away. Okay, if at all the sheath of abdomen gives away. Okay, this is what is referred to as your burst abdomen. Are you understanding? If the sheath of the abdomen has kind of got separated, this is what you refer to as a burst abdomen. What is a burst abdomen? That is the sheath of the abdomen has basically given away. Now these things can happen because of the problem with the surgeon, because the suturing was not done in a proper manner. Why does this occur? Why does the burst abdomen occur? Burst abdomen occur. So the burst abdomen can happen because of the surgeon's fault. That is, the problem is with the suturing, or it can happen because of the patients. Why patients? Because let's assume that the patient is basically having COPD. What's going to happen? The patient will keep on coughing, and whenever the patient coughs, there is an increase in the intra-abdominal pressure. Because of the increase in the abdominal pressure, the wound basically tries to kind of give away. You understand my point? So this is what you need to understand. Why does this particular burst abdomen occur? This occurs because of these particular things. Now the important things, the two most important MCQs over here is that when does it occur? When does it occur? So the most common presentation of this particular stuff is on post-operative day 5 to 7. Very, very important, guys. Okay, so when does it occur? It usually occurs on the post-operative day 5 to 7. This is the most common time when this particular thing is going to occur. And what else you need to understand over here? So post-operative day 5 to 7, that is the first thing. The second thing which you need to understand over here is that what is the surest sign? What is the surest sign? So surest sign of this is basically the copious amount of the serosanguinous discharge. So serosanguinous discharge. This is also called as a Salmon sign. What is it called as? It is called as a Salmon sign. Very important, guys. Okay, so this is what is referred to as your Salmon sign. What is this particular Salmon sign? That is large amount of the serosanguinous discharge is coming from this particular wound. So on the, like, if at all they give you a clinical scenario that there is a patient who has what you call as suffered from a abdominal, like burst abdomen, and after the burst abdomen, like the patient has undergone a laparotomy, and after the laparotomy on post-operative day 5 to 7, there is a large amount of the serosanguinous discharge which is basically coming from the wound. Then what is the diagnosis? The diagnosis of that particular patient is the burst abdomen. Okay, now just look at this particular kind of question and put your answers in the comment box. Just do that. I'll just kind of let you know what is the answer over here. Just 1 minute, guys. There's a bit of a technical issue. Just give me 2 minutes. I will join back. Till that, you can just answer this particular question. Yeah, sorry guys, I'm really sorry for this. Yeah. So what is this particular question is? The question is that there is a patient who is admitted to the hospital for the long period of time, following which she developed there is a swelling in her legs and blah blah blah. What is the investigation of choice? Yes, you are basically trying to look for a DVT over here, and the investigation of choice for that is a duplex imaging. That is a Doppler. Okay. So what is this? This is what is a Doppler. We are basically trying to look for the Doppler, and that is what is like the duplex imaging Doppler, all those particular things. Yeah, that's what you need to understand over here. Okay, right? Okay, now let's talk about the DVT. Okay, let's talk about the DVT in a bit more detail over here. What about the DVT? DVT basically means the deep venous thrombosis. And what is the risk factor for the development of a DVT? Can you please help me with this? Okay, so what is the risk factor for the development of the DVT? The risk factor for the development of the DVT is immobilization. Immobilization. Okay, so after the surgery, let's say if at all the patient is not moving around, and let's say if at all there's a patient who is having a pelvic fracture or something like that, where the patients are not able to move around, then what can happen? There can be a venous stasis in the lower limbs. Okay, so there can be venous stasis in the lower limbs, which can ultimately lead to the formation of a deep venous thrombosis. Okay, so patients can lead to the formation of a deep venous thrombosis. There can be other things as well. For example, pregnancy, hypercoagulable state is there. Then there is some pelvic tumor. All those are the reasons as well, but the most common reason is immobilization. Immobilization is the most common reason why the patients may land up into deep venous thrombosis. Okay, now what you need to understand is, so whenever there's a patient who is having a DVT, what is the clinical features? Okay, what are the clinical features of that? The clinical features of this is that there's a patient who is having pain and there is a swelling of the lower leg. Okay, so there's a pain and there's a swelling of the lower leg. All these particular things are there in the patients with the DVT. That's all fine. Okay, now okay, investigation of choice. So you would have heard of this Homan sign and you would have heard of this perch sign. So what is a Homan sign? Homan sign is basically that when you do a dorsiflexion, there is a resistance to the dorsiflexion of the lower leg. That is what is called as a Homan sign. Then there is something which is called as a Pratt sign, where you basically squeeze the calf muscles, and when you squeeze this calf muscles, there is a pain. But all these particular things are not done. So all those particular tests are not done. Why? Because there is a risk of development of a pulmonary embolism. So by doing this Homan sign and the Pratt sign and everything, you are actually increasing the risk for the pulmonary embolism. That is why they are not done. And the investigation of choice over here is a duplex scan or a Doppler ultrasound or something like that. Okay, so that's what you need to understand. The investigation of choice over here is the duplex scan or the Doppler ultrasound. The management of this is that you give the patients warfarin. Warfarin is basically kind of given in order to manage these particular patients. So you start the low molecular heparin and the warfarin at the same time, and then ultimately you shift the patients from the low molecular heparin to the warfarin, and then you continue the warfarin for around at least 3 months. Around 3 months you basically have to continue the warfarin. Okay, I hope you have understood this particular point. Now let's move to the next question. What is the most likely age of presentation of the jaundice to be classified as the biliary atresia? So biliary atresia is the congenital anomaly where the patients present to you with a jaundice, and the neonates, they basically present with the jaundice. Okay, now what they're trying to ask you is that after what time duration you will tell that, you know what, probably this particular patient is having a biliary atresia. So the answer to this particular question is 2 weeks. Okay, so what you need to understand is that till 2 weeks the patients may have what you call as a physiological jaundice. Physiological jaundice. But if at all the jaundice prolongs, if at all the particular jaundice, this basically prolongs beyond 2 weeks, then you have to kind of think in the terms of your biliary atresia. Okay, then you have to kind of think in terms of the biliary atresia. Okay, so if at all the jaundice is basically prolonging beyond 2 weeks, then you have to kind of think in the terms of the biliary atresia. I hope you are able to understand what is the biliary atresia. So the bile duct and the common bile duct and everything, that is kind of not developing in the kind of neonates. That is what is a biliary atresia. So the characteristic history will be that this is what is the, okay, so biliary atresia, this is the most common cause of the jaundice in neonates. Okay, so what is this? This is the most common cause of the jaundice in the neonates. What is it? It is a biliary atresia. Okay, I hope you are able to understand this particular point. Yes, so this is also the most common indication of liver transplant in children. Okay, in children, what is the most common indication of a liver transplant? It is basically your biliary atresia. I hope you are able to understand this point. This is the most common indication of a liver transplant in the children. Now, what you need to understand over here, what is the investigation of choice? What is an investigation of choice in these particular patients? The investigation of choice in these particular patients is an ultrasound. Okay, so on the ultrasound, what you're going to find? You're going to find a triangular cord sign. Triangular cord sign. Okay, so because the gallbladder is not developed, all that is present over there is a fibrosis, and whatever the fibrosis is kind of present over there. So investigation of choice over here is a triangular cord sign. Investigation of choice is the ultrasound. That is what is a triangular cord sign. Now what you need to understand is that biopsy is also a good investigation, but biopsy, liver biopsy, this is basically done. Why it is done? This is basically done because you want to kind of, so what do you get in the liver biopsy? So what you get is a biliary cirrhosis What do you understand with the biliary cirrhosis? That because of the bile basically stasis is there, because of that the liver basically fails up. So this is what is a biliary cirrhosis. So what we get is a biliary cirrhosis on the liver biopsy. But what you need to understand is this liver biopsy is basically done to rule out, this is basically done to rule out other causes of jaundice in neonates. Are you understanding my point? So this is basically done in order to rule out other causes of the jaundice in the neonates. I hope you are able to appreciate this particular stuff, guys. So this is basically done to rule out other causes of the jaundice in the neonates. That is why you basically perform this particular liver biopsy. Now, there's one particular surgery which you basically do in these particular patients. This is what is called as a Kasai procedure. Okay, Kasai procedure. So what is this particular Kasai procedure? This is what is called as a portoenterostomy. So why? Because the most common type of the biliary atresia. So there are different types of the biliary atresia. The proximal type, or involving the porta hepatis, that is what is the most common type of the biliary atresia. Okay, and what is this Kasai procedure? So I hope you're able to understand. This is what is your porta hepatis. So you are basically directly anastomosing the porta hepatis to the intestine. It is not the what you call as a kind of hepatico-jejunostomy or something like that. No, in this we do not have a hepatic duct. What you basically have is a porta hepatis is basically joined to the intestine. But this is usually kind of done. That's fine. Okay, so two things if you want to remember over here. By when it should be done? Ideal time to do this is basically before 60 days. Before 60 days of life, this has to be done. Okay, this has to be done before 60 days of life in order to help, in order for this particular procedure to be helpful to the patients. And important thing is, what is the treatment of choice? So the treatment of choice is ultimately a liver transplantation. So ultimately the patients will need the liver transplantation. Are you understanding my point? So what is the treatment of choice? Treatment of choice is a liver transplantation. I hope you are able to understand this particular point, guys. Okay, very, very important. Okay, now let's talk about this. Which of the following kind of manifestations is not typically associated with the MEN1 syndrome? So multiple endocrine neoplasia type 1, which of these is not associated with the MEN1 syndrome? Parathyroid hyperplasia, pheochromocytoma, pituitary adenoma, or the pancreatic neuroendocrine tumor? So please try to understand, the MEN1 syndrome is basically a syndrome of 3 P's. So what are included? Parathyroid hyperplasia is a part of it, pituitary adenoma is a part of it, pancreatic neuroendocrine tumor is a part of it. The answer over here is a pheochromocytoma. Pheochromocytoma is not a part of your MEN1 syndrome. So the MEN syndrome is again a very, very important thing. So let's try to talk about this. So what we have a MEN1, we have MEN2A, and we have MEN2B. Okay, so we have MEN2A, and then what we have is a MEN2B. So in the MEN1 syndrome, what we have, this is basically the syndrome of 3 P's. So what are the 3 P's? We have a involvement of a parathyroid. So parathyroid hyperplasia, whatever, adenoma, or whatever you want to call it. Then we have the involvement of a pituitary. So in the pituitary, what you basically get is a adenoma, or a microadenoma, or a macroadenoma. So in the pituitary, you basically get that. And then what we have is a pancreas. So in the pancreas, what you basically get is, in the pancreas, what you basically get is the pancreatic neuroendocrine tumors. Okay, so these are the 3 things which you basically get over here. So in the pancreas, what you basically get is a neuroendocrine tumor. So which is the most common pancreatic neuroendocrine tumor which is basically present in the MEN1 syndrome? The answer over here is gastrinoma. Overall, the most common pancreatic neuroendocrine tumor is your insulinoma, but the most common pancreatic neuroendocrine tumor in the MEN1 syndrome is gastrinoma. Are you understanding my point? Overall, the most common pancreatic neuroendocrine tumor is your insulinoma, but in the MEN1 syndrome, it is gastrinoma. I hope you are able to understand this particular point, guys. Okay, please do remember that. Okay, now in the MEN2 syndrome, what you're going to have, in the MEN2 syndrome, you are going to have, this is basically the syndrome of 2 P's. So what are the 2 P's here? There's involvement of a parathyroid. So you do get a parathyroid adenoma and all those particular stuff. And what you basically get is a, you basically get pheochromocytoma. Along with this, the additional thing which you basically get is a medullary carcinoma of thyroid. We talked about that, right? The medullary carcinoma of thyroid is basically associated with the MEN2A as well as the MEN2B syndrome. Medullary carcinoma of thyroid you basically get over here. Okay. Along with that, what you basically get over here, you also get pheochromocytoma. Pheochromocytoma. So in the MEN2B, what you basically get, this is what is the syndrome of 1P. So MEN1 is basically 3P, MEN2 is basically 2P, MEN2 is basically 2P, MEN2B is basically 1P. Are you understanding my point? So this is what you need to understand. 3P, 2P, 1P, parathyroid, pituitary, pancreas, parathyroid and pheochromocytoma, and only pheochromocytoma. So, okay. And additional important thing which you need to understand is that in the MEN2B syndrome, along with these particular things, there are also other things like marfanoid features. What you basically get is a marfanoid features. So what do you understand by the marfanoid features? This basically means that there is a like increase in the arm span, like the hands and the legs are basically increasing in length and all those particular stuff. Along with this, what you basically get is a mucosal what do you call as a ganglioneuromas. Okay, you understand my point. So plexiform neurofibroma, mucosal ganglioneuromas, all those particular things which are going to get in the MEN2B syndrome. So if at all they mention you that there is a patient who is having a thyroid swelling on the FNSA, it is diagnosed as a medullary carcinoma thyroid, the patient is having a pheochromocytoma, just this information is given, it is a MEN2A syndrome. But along with this, they kind of give you that there is a patient who is having a myofanoid features as well, and there is a mucosal paragangliomas and neurofibromas and all those stuff. Then it is basically dealing with a MEN2B syndrome. So please try to understand this point, okay? And yeah, just last thing which I want to emphasize over here, the parathyroid involvement is basically present in the MEN1 and the MEN2A. It is not a part of your MEN2B. Okay, I hope you have understood. These are the MEN syndrome, very, very important. Okay, now let's move to the next question. So the next question which we have is that, yeah, so there's a 45-year-old male presents to the emergency department with the severe abdominal pain radiating to the back. The laboratory investigations reveal that there is an elevated amylase and the lipase level. Which of the following should be avoided in the management of these particular patients? Okay, so here what you need to understand is that there is a patient who is having the features of your acute pancreatitis. Okay, so what are you having? You're basically having the features of your acute pancreatitis. Okay, so whenever you have a features of your acute pancreatitis, what you need to understand is that which of the following is not kind of done in these particular patients. Can you please help me with this? Which of the following is not done? Okay, so in these particular patients, what you basically do not do is, yes, nil per oral to avoid the pancreatic stimulation. No, in today's time, the management is that early initiation of the oral feeding, that is something which is kind of given. Okay, early initiation of oral feeding is kind of preferred. Parenteral nutrition preferred for 2 to 3 days over the nil per oral approach. Why so? Because what you need to understand is that, okay, so this is also early initiation of the TPN can basically done in the severe acute pancreatitis, not in the mild forms, but in the severe acute pancreatitis, you basically have this what you call as a, you can initiate the TPN and all those particular things. That is what you need to understand over here. Now, but giving the bowel rest is not a kind of feature of this. Okay, so please try to understand. Giving bowel rest is not a feature of what you call as your acute pancreatitis. Okay, so giving the bowel rest is definitely not a feature of your what you call as an acute pancreatitis. So here, what you have to do is early initiation of the enteral feeding. That is what you need to understand over here. Okay, now the next question which you have over here is that during an endoscopy, a man found to have a squamocolumnar junction located proximal than the normal. Which of the following condition is most likely responsible for this particular finding? Okay, so the squamocolumnar junction is basically moved a bit proximally. So which of the kind of condition is most likely responsible for this? Achalasia cardia, sliding hernia, rolling hernia, or the gastroesophageal reflux disease? Can you please help me with this? Which of these is kind of associated with this? Okay, yep, can you please help me with this? D. Yes. What is it? It is basically a gastroesophageal reflux disease. Okay, what is this? This is what is a gastroesophageal reflux disease. Okay, so yeah, what we are dealing with is a GERD, gastroesophageal reflux disease. No. Okay, I'm really sorry for this, guys. I actually was looking at some message over here. Obviously, the answer is not GERD, guys. Come on. Please try to understand over here. It is not GERD at all. What is it? The answer over here is sliding hiatus hernia. We did not kind of read the question in a proper manner. During endoscopy, the man is found to have a squamocolumnar junction located proximally than normal. So, squamocolumnar junction has been located proximally. So they do not kind of say that there is a conversion of the squamous epithelium into columnar epithelium or anything like that. I understand my point. They are basically trying to say that the GE junction has kind of moved proximally. So what is this? This is what is a sliding hiatus hernia. Okay. What is this? This is what is a sliding hiatus hernia. I'm really sorry. Even with the flow, looking at the comments, I also marked it as D. I was actually looking at something. So please try to understand. The answer is sliding hiatus hernia. Did you understand the reason why? See, in the GERD, what you need to understand, in the GERD, if they wanted you to mark the GERD, they would have given you that the squamous epithelium has been converted into the columnar epithelium. Okay, so the squamous epithelium converting into the columnar epithelium is a GERD. But when the GE junction is moving proximally, that is what is a sliding hiatus hernia. Are you understanding my point? I hope you're able to understand this point. Okay, so answer over here is definitely the sliding hiatus hernia. So let's talk about the hiatus hernia. Okay, so let's talk about the hiatus hernia. So what you need to understand is the hiatus hernia can be of two types. They can be either sliding and they can be either rolling. Okay, so there can be a sliding hiatus hernia or they can be a rolling hiatus hernia. What do you understand by the sliding hiatus hernia? In the sliding hiatus hernia, the GE junction, it moves proximally. So if at all the GE junction is moving proximally, what is going to happen? The intra-abdominal length of the esophagus is going to go down. And if at all the intra-abdominal length of the esophagus is going to go down, so try to understand over here. Okay, I'll get back to you. Okay, I'll tell you, I'll let you know what you need to understand over here. Okay, so the intra-abdominal length of the esophagus is going to go down, and because of this, the patients are going to have a GERD. Okay, so because of this, the patients are going to have a GERD. Okay, now in the rolling hiatus hernia, what you need to understand, this is also called as a paraesophageal hernia. Okay, now before I talk about this particular rolling hiatus hernia, let me just address to the doubt of Death Bhai. Okay, so Death Bhai, please try to understand over here. So I understand your doubt. So what he's basically trying to ask is, so can we appreciate the anatomy on the endoscopy? Anatomy of the G junction? Probably not. But let's assume that there is a patient who is having this particular esophagus, right? So there's a patient who is having this particular esophagus over here. Okay, now let's assume that this is the squamocolumnar junction. Okay, let's assume that this is a squamocolumnar junction. Now let's assume that there is a GERD happening in these particular patients and the squamous epithelium is getting converted into the columnar epithelium and everything. It is not going to happen at one, like it's not going to be a clean cut like this, right? It's going to be at some places the columnar epithelium is going to be like this. I understand your point. It's going to be like a wavy kind of a thing. So if at all they would have mentioned to you that the squamocolumnar junction is not at one level, or maybe the other way of kind of mentioning it, this is that the squamous epithelium is converting into the columnar epithelium, then it is a GERD leading to the columnar metaplasia. That is what is your Barrett's esophagus. But here they did not mention anything like that. They just said that the squamocolumnar junction is moved proximally. Just imagine that if at all there is a sliding hiatus hernia, if at all, let's say there is a sliding hiatus hernia, there also what is going to happen is that the squamocolumnar junction will move proximally. And what, like, if you want to understand proximally, how did we calculate? So from the length of the incisor, right? It should be at around 40 centimeters. Are you understanding? But if at all, let's say a bit proximally, then we can say that, you know what, the squamocolumnar junction has moved proximally. And if at all there is a uniformity in that, then probably it is a, what you call as a hiatus hernia. Are you understanding my point? I hope you got that. Did by? Okay. Got it. So this is what is a sliding hiatus hernia, which I've drawn over here. Let me just also draw the rolling hiatus hernia for you. Okay, so let me just draw the rolling hiatus hernia also for you guys. Okay, so what is the rolling hiatus hernia? In the rolling hiatus hernia, the part of the stomach is basically coming up. Okay, so the part of the stomach is basically coming up. That is what is called as the rolling hiatus hernia. So what you need to understand over here, that is the stomach part is basically herniating, but the squamocolumnar junction is basically at the normal level. This is what is a type 2 hiatus hernia or the rolling hiatus hernia. Okay, right. So this is what is a rolling hiatus hernia. So will there be GERD in this? So no GERD in these particular patients. Okay, no GERD. But what you're going to find in these particular patients is there's going to be the ulcer over here. This is what is called as a Cameron's ulcer. So what you're going to find, you're going to find a Cameroon's ulcer in this particular herniated part over here. Okay, so whatever the stomach has basically come into the thoracic cavity, there because of the ischemia, okay, because of the ischemia of this particular part, what can happen? There can be an ulcerations in this particular mucosa, which is basically referred to as your Cameroon's ulcer. So this is because of the ischemia of the mucosa of that particular part of the stomach, which has gone into the thoracic cavity. I hope you're able to understand this point. Okay, now. Okay, so this is what is a fundoplication, and the fundoplication is basically going to be needed in the sliding hiatus hernia. So you basically reduce it down and then you kind of do the fundoplication. That's all fine. Also used for the GRD, that's fine. Okay, now a 45-year-old female presents with an abdominal kind of a distension and the discomfort. Imaging studies reveal that there is a diffused intraperitoneal mucinous ascites and the mucinous implants in the peritoneal surface. The histopathological examination of the lesion demonstrated abundant extracellular mucin, scattered blah blah blah, neoplastic epithelium. What is the most likely diagnosis? So what is this? This is what is a mucinous cystadenoma. So this is usually what happens is that it can happen because of the ovarian tumor or because of an appendix. So let's say if at all there is a mucinous carcinomas of the appendix or something like that, if at all they rupture. So what can happen? The entire, like when you, this is a characteristic description of this. Okay, this is a very, very characteristic description. So when you do the laparotomy, in the entire abdomen, there are mucinous deposits into the peritoneum and the other places and all those particular stuff. And yeah, that is what you basically say that, you know, what we are dealing with the mucinous cystadenoma. So this can happen, primary can be present in the ovary, but many times it is basically present inside the appendix, and the appendix basically bursts open, and that is what you need to understand over here. It is not the carcinoid tumor, Dr. Ishan. Okay, I hope you got this. It is not the carcinoid tumor. Okay, so very, very characteristic description. The management of this is debulking surgery and the intraperitoneal chemotherapy. That is what you basically give in these particular patients. Okay, please try to understand this point. Okay, now okay, so it is around 8:20. What we'll do is let's take a kind of break. Let's take a kind of a dinner break. So the class will continue till around 11:30, 12. The class might continue till around 11:30, 12. Let's take a break for around, let's say 35-40 minutes. Let's meet back at 9 o'clock. Okay, let's meet back at 9 o'clock, and from 9 o'clock we'll kind of take the session till around 11:30. Will that be okay with you guys? Okay, so from 9 o'clock till 11:30, 12 we'll kind of take the session. Okay, so let's break for the dinner.